Good morning, everyone. My name is Dr. Shukdev Dara. I'm here to formally open up a new society, the American Society of Endoscopic and Interventional Spine Surgery. And we are so proud to announce that we are having our first meeting here in beautiful New Jersey. We've got a wonderful set of speakers all around the globe to present the most important and the most relevant data in endoscopic spine surgery. I am so happy that we were able to get this started in a short notice. We have a lot of invitees globally, and we hope everyone will be joining us soon. I'll give the floor over to Dr. Soon. He's going to present a little short introduction.
Hello, everybody. My name is Dr. Bong-Soo Kim. I'm from Temple University, Philadelphia. I'm one of the neurosurgeons in Temple Hospital. It is my great honor to be here. Thank you so much for Dr. Data to arrange this amazing conference in a short period of time. I'll be moderator today. First, I introduce Dr. Yanni about his clinical experience of transforaminal decompressions. Dr. Yanni, please.
Good morning. Thank you, Dr. Data. Thanks for the invitation. Thanks, everybody, for being here. That tells us that you guys are all interested in endoscopic, minimally invasive procedures, which I believe this has been all of our passion for a while. So we've been doing endoscopic for, I would say, over 18 years now. Started with Dr. Jasper, my first case. And then, you know what, we've been mentors, going, you know, to cases, going to conferences, and, you know, we go into peers, and I think it's, you know, endoscopic is a passion, it's the future, it's, we see it in our patients. You don't have to cut everybody open to getting better. So when Dr. Dara, you know, asked me about, you know, doing transforaminal speech, I said, you know what, let me bring some, you know, my cases, some of the things that we do. I don't want to make it just a regular, boring lecture. Here it is, you have to put the needle. You know, we have all those lectures, but I'm sure everybody gets it from all the Cadaveric courses. So, you know, I want to present those cases, and, you know, if anybody has questions after that, we can take it from there. So I'll start with, so if you're interested in actually learning about the procedure, we have, you know, I did do Cadaveric. That was an asset in Las Vegas, and that was recorded by Paincast. So you can go to Paincast, check it out, you know, write my name, write endoscopic, and, you know, it's going to show how you do the procedure. I am mostly inside, outside guy. I do outside, inside if it's only needed. I know it's always been like, oh, inside, outside, right? If I have usually disc herniation, decent size, I go from inside. Because my belief it's better I take the herniation from its roots. If I'm doing foraminoplasty, I usually go from the outside, inside. If it's extruded disc that has separated, I go from the outside, inside. So it's really about the comfort. Yes, everybody starts with inside, and then they start doing outside. So let me present those cases. It's, you know, first case I have, it's a 48-year-old female with back pain, radiating to bilateral lower extremities, more on the left than the right. She had decreased sensation in the L5 nerve distribution bilaterally, decreased knee jerk, and decreased ankle dorsiflexion. We get an MRI, and that is the MRI. Nice, decent herniation at L4, L5. You know, a lot of people would say, oh, this case has to be done transforaminal, interlaminar, because of how big is the herniation. You know, I'm just gonna, you know, those are unedited videos. So I'm just gonna go through them with really the most important parts. So here we're inside the disc. First, what I do is I trim my anatomy, as I call it, or I define my anatomy. So I always want to see the annulus. My annulus is like my base, my quarter back, because from there I know where I am, honestly. Of course, it's the more cases you do, you know what kind of anatomy it is. So started doing endoscopic from inside outside, and just been doing more and more. So you can see in that case, trimming the anatomy as we were talking, right? I'm just going to go in areas where it's really important. So because of that decent herniation, I think we had to do a cut in the annulus. And you can see there are really angry vessels in the epidural space. And you can see how that big herniation is coming out with just like 3 minutes of an endoscope time. But it's all about, putting the needle first. Here this herniation just keeps coming up. Here it is, we're clearing. And usually when I see the signs of bleeding, I know I have started really decompressing nicely. Because of those inflamed vessels, now you took the compression out of them, so you really, we're gonna take our time, and we'll see it in the next case. A 40-year-old male, he enjoys basketball. He was unable to play for 2 years, failed conservative, failed epidurals. He was having progressive pain and weakness. He had 3, 4, 5 in the right ankle dorsiflexion. That's a really nice, decent right herniation that we see in the axial. So for this case, I'm looking at the axial, and I think it's going to be really very hard, if possible, if I can just go transforaminal this out. So what I did is I did foraminoplasty first. I cut on the bone, so that would make me land on the disc. So we'll look at that case briefly too. So you can see in the upper left corner, that is, I have a picture-in-picture in my system, so I can see from my scope exactly where I can have my x-rays. So you can see in the x-rays, I am half in, half out, mostly out. Why? Because, as I said, I'm doing my first. And so I duck under the facets. This case was done with purely endoscopic bursts. Sometimes I use reamers, and we'll see in the next case. So if we're doing a foraminoplasty first, you need to take your soft tissue out. That's what I'm doing here, just cleaning soft tissue first. Here it is, after I cleared my soft tissue.
O'clock is the superior teacher.
12,
process, right?
exactly, Dr. Jasper.
I see the epidural space already breathing.
Yep. clearing, opening after I did my foraminoplasty, still clearing. Go fast forward for a little bit. Now I'm starting to actually go after my herniation. As you guys can see, it was pretty nice, decent one. So now I'm making the cut in the annulus. And I always take a look at the tip. Always take a look at my tip. I never cut without looking, you know, I have to see my tip. Here it is, the herniation starting to appear after I did my foraminoplasty. And as I'm using the sheath is to push in, like burying the disc herniation, so the disc herniation can start actually coming out.
Yeah, I meant to talk about the end, but I'll present a little bit of the image.
It's been a disc there for a while, so I got a lot of fibrous tissue around it. And you can see in the top left, literally, I mean, the whole sheath is outside the disc. All this is kind of the herniation, distorted anatomy.
Nice one.
Patient did great. So I use a lot of times my cannula to change things, open anatomy, push on it. It starts bringing that herniation. The other thing that I use is the nerve hook. So you can see as I'm just putting the herniation in the middle of my sheath, and it just keeps giving it pressure. Still doesn't want to come out. So I still had to cut a little bit more, cut a little bit more. Bleeding started, and now you see how big is that, you know, big herniation coming out. Case 3 is an 80-year-old male complaining of neurogenic claudication. He had bilateral lower extremity with radiation. He had a vertiflex, which provided him some back relief. However, he was still complaining of right lower extremity and right L4 distribution. We get the MRIs, and here it is. You can see the nerve is really pushed, severe foraminal stenosis. So we did foraminoplasty. See all the pictures. You can see on the left side how in the sagittal, how it narrows our foramen. Central canal got better. You can see on the top left, here's the vertiflex, and I put my scope in. So cleaning anatomy first. Then we use our burr get our foraminoplasty.
What system you use for that?
That is the Wolf framers.
Wolf?
Yeah, that is the
Dr.
Wolf
Yanni.
framers. Yeah.
We are running behind a little bit, so these two.
So here we did our RF, and we can open up, use the kerosene. I got all the way, you can see the ligamentum flavum from starting to appear all the way in. Still clear, 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 clear. And you can actually, now you see how the nerve, here's the endoforaminoplasty, you can see the nerve on the right side. That patient actually did really well, okay. And I have the fourth case. It's a very interesting case. It's actually just did it last week. A 76-year-old male complaining of left lower extremity radiculopathy. He has L1 to S1 fusion. He had decreased sensation left L5 S1 distribution. CAT scan showed moderate severe left foraminal stenosis. The plan was to do left L5 S1 foraminoplasty. But looking at the foramina, it's really very tight, very tight. And the guy has fusion, a lot of bony there. So here's my needle. I did do this case, don't buy a needle, guide wire. I targeted to, as you see, lower part of the pedicle. Here you can see I used my sequential dilators, reamers, and you can see from outside in, haven't put my scope. All this is just pure x-ray. I made the opening and then I put my scope in. Here you can see the video of it. You can see after, as soon as we get in, that is the picture we're going to see. If the foramen is open a little bit, but however I need to clean it up more. We cleaned soft tissue. We used the burr, and then use the kerosene, and you can see in the top left, here's the lateral view, and you can see the AP view.
It's pure
Parameters.
articulating process.
Exactly.
The
So
apex, right?
I think those cases can only be done endoscopically. There is no kind of open procedure unless you have to come transforaminal. The beauty about this is you go in, open the foramina, you really, the nerve is protected, and then you put your scope, take a look, and you clear everything. And you know, this patient really did very well right away. Okay, thank you very much. I want to share a couple of cases with you.
We have to change the cameras. Just take us a second. We're going to just switch the computer, and then the next speaker is going to come on.
Okay, so during the changing computer, Dr. Yanni, may I ask you how confirm the 5S1 that the level is causing patient symptoms? Any process you confirm the pain generated at 5S1 parameter?
Yes, yes. So I'd like to examine the patient clinically, see if it's L5 or an S1.
Okay.
Number two, we do this comes, you know, can be false positive from before.
Okay.
And then we can try an epidural and we'll see how the patient goes. But actually, it's a garbage in my body. I want you to do something to fix it. So, you know, we can see that, and really the MRI is mostly showing just the L5 S1 foraminal narrow.
Okay. Thank you so much.
All right.
Okay, the second speaker is Dr. Gangtin Lim from South Korea. He is really expert of endoscope surgery. He does at least 700 cases per year endoscope surgery. I've been there a couple of times. He's amazing, skilled neurosurgeon. He's presenting his experience of a posterior stenotic lumbar decompressions. Dr. Lin?
Okay, thank you. Thank you, Doctor, and
Wants to make sure he has
for
got thing with sound.
inviting me. It's okay? Yeah. And it's a great honor to be here and to have a chance to talk about the endoscope surgery today. My name is Lim, came from Korea. I'll talk about the clinical experience of endoscope spinal surgery. I will give approach two times. The first the lumbar, the second is the cervical case. So we are very familiar with the endoscope surgery, the transforaminal for the discectomy. But you know the Korea and USA also aging society, becoming aging society, patients have the stenosis and this disc, the both. So that's why we have to solve the problem, the disc and the stenosis at the same time. That's why the transforaminal small endoscope is available for both pathology. That's why we had to manufacture a new endoscope. And 2016, the Maxima company in Germany accepted my idea, so we were able to release a new endoscope system. So it's more out diameter is about 8 millimeter, and the length is 113, and working channel is 5.5. So we can use a 1, 2, 3, 4, 5 millimeter calcium punching, and this with this the length we can even the obese the patient can be operated with a small skin incision, just 7 millimeter. That's why which can reduce infection rate and can reduce the use of antibiotics. So my endoscope is 8 millimeter out diameter and 5.5, right? Not for working channel. And you can use a 1 to 3.5 millimeter calcium punching. So with this the endoscope, I could try the endoscope surgery for the stenosis. Just one level and the two level with one skin port. We can do 1, 2, 3, the multiple level decompression for stenosis. And at the same time, 3 plus 2 means the first central stenosis 3 level with one skin port and 2 level foraminal decompression. Right? And so we can apply the endoscope surgery for the stenosis, also the 1 level, 2 level, 3 level, and we can do the fusion surgery and the HDF. So the afternoon I'll show you how to approach the anterior cervical for the HDF endoscope. So all my surgery I do in my operation room now is 100% endoscope surgery. No, the open surgery. So 8 millimeter diameter endoscope surgery. So most of the patients have suffered from the stenosis, have the hypertrophic facet joint. That's why the very narrow space of a lamina. So 8 millimeter out diameter is good for the landing on the laminar space, and small the 8 millimeter diameter can close observation of the after space, but the bigger size is very difficult to landing on the laminar space. So distance from the range and jewelry is very longer, so it's very difficult to find outer structure in the after space. And then you have to so the smaller the endoscope is available to move to watching the contralateral side. So 90 degrees tip of endoscope is very important. Right? So most of the endoscope like this 25 degree, but my endoscope is at right angle tip of endoscope. It's very important because endoscopy is the water-based operation, right? So input and output, right? So the tip of the 90 degrees will provide the input-output water pressure is the same. That's why the tissue, right? The debris are easily discharged to outside. But it's like at the 45, it's very difficult, hard to get outside of the debris. Right? So that's why I recommend the 90 degree tip of endoscope is better. Okay, the endoscope is 10 degree lens angle. In the lateral space is very narrow space. So with the 10 degree lens angle, we can watch every space anatomy structure very closely. Then the wide angle endoscope. And the 10 degree lens angle to see the ipsilateral underside wear is very useful. But for instance, the 50 degree lens angle to see the underside wear ipsilateral, we have to cut more the facet joint, right? It's like a movie, right? Okay, it's the facet joint, right? To watching the ipsilateral, the underside wear, we have to cut the facet joint, right? Same again. Yeah, right? So 10 degree angle is the better to see the underside of the wear without the damage of facet joint. That's why 10 degree angle. And about the crescent punch. So my crescent punch is 140 forward of the tip angle. So where the maintenance the operated angle to the SAP and the ligament flame. Do not use it, it's 90 degree. Right? It's very difficult to bite any structure in the space. And the endoscope is 113, very short, the endoscope. And the same, the crescent punch is also the short. The crescent punch is a more strong bite for force the crescent punch. So we can be able to quickly eliminate the target. So in Korea, so endoscope surgery has become the most commonly performed spine surgery now. And the patient are very familiar to searching the internet what is to know what is endoscope, what is the open surgery, and then they want to get the endoscope surgery now. Right? That's why in Korea, if the spine doctor do not endoscope surgery, it's very hard to survive as a spine surgeon.
If you don't do endoscope.
Yeah.
Very interesting. Here it's hard to survive if you do endo.
So you know
What's the reason, Doc? Why is only Korea? It's really the country that has
because with the endoscopy we can do everything, every pathology, the discectomy and the decompression for stenosis and the fusion surgery also. Most of the spine doctors can do. It's very popular. And also the patient knows information about the endoscopic surgery. Okay. So it's published the paper on the endoscope. It has the increasing every year, and usually it's China and Korea, USA. Okay. So meaning that many spine doctors are interested in the endoscope surgery. So what is this? You know that this is the movie, right?
Yes.
War of the World, the actor was Tom Cruise. So in this film, you can find what is the ideal endoscope. Right? So there should be not to damage or another structures, and must have ability to control the direction under the clean surgical view. It's an ideal endoscope system. Okay. So now I think the endoscope surgery is similar to the movie and the video game, because it has to eliminate the target, the enemy, in confined the narrow space without damage of numerous structures. So we can apply the endoscope surgery for any pathology, like for decompression lumbar and both decompression, and you can use the endoscope surgery for the fusion surgery and the survival case. So we can remove the fragment, and we can wide the foraminal stenosis and canal stenosis in case of myelopathy. And then we can apply the endoscope surgery for the HDF and high cervical C1 to reversible. So what is the advantage of endoscope surgery? It's, the first good thing is we can preserve facet joint and post ligament complex, very important. Pre and post operative, right? What do you think? No damage of the facet joint, and no damage of, we can preserve post ligament complex that maintain the stability post operative. Am I right? And what happens in the open surgery? The first, we have to sacrifice the muscle and the post ligament complex to detach the muscle from the spinous process. It's open the decompression. So, but the endoscope, there is no any damage of normal anatomical structure, especially the post ligament complex. And you know very well about post ligament complex is main structure that maintains the stability in the spine. It's corresponding to main cable in suspension operation. If the post ligament complex is damaged, all structure will eventually collapse like this. So case some patient have some instability L4-5, but patient have a radical leg pain. It's stable, so stenosis with endoscope. You can use endoscope for decompression. There is a fat atrophy. So just besides spinous process, we can insert endoscope, and post-operative MRI CT scan shows no damage of facet joint and post ligament complex. And 1 year the follow-up period, there is no any the change in stability level 5. So it's my pain for the case patient have sclerosis and radical pain. So the most spine surgeon will try the corrective sclerosis surgery like this. It's my case. And then 2 years later, there has some junctional problem. I had to fusion extended surgery more with this. It's big surgery, right? After then, the current strategy has changed to first decompression endoscope. Right? Instead, to create the tunnel through which the nerve can pass well. We can make a tunnel. So we know how to make the stenosis tunnel widen for the compressor nerve tray with endoscope. Right? So the advantage of endoscope surgery is that we can perform the endoscope surgery for lumbar under the local anesthesia, decompression, discectomy, and the fusion surgery also. And we use the large amount of the water. It's a water-based operation. So that's why we provide good visualization, clean the surgical tube. And with using the larger amount of water is where the infection rate is very rare, and we can preservation father joint post-lumbar complex, and that's why we can fusion surgery can be avoided, and we can do multiple level, multiple region. It's a case L45 pre and post operative, the chest vacuum and axial lobes, pre and post operative. No damage of fast joint and no muscle damage, and CT scan also. It's my paper about the endoscopic decompression, and it's also my papers. And the two level.
So, Doctor, can you mention your difference, uniportal versus biportal?
Yeah, I'll
I
talk
know.
about this.
Okay.
Yeah. It's a two level, right? The two level, pre and post operative, right? The axial, pre, post operative, right? So, but it's that we can do the just one scalpel, not two scalpel. I'll talk about this. And the three level, right? 2, 3, 3, 4, 4, 5, and the axial also narrow space. First 2, 3, and post operative. And then
You do it in one day?
yeah, it's a one skin port. Right?
You do it all posterior approach?
Yeah, it's a one skin port, right? 1, 2, 3. Right? One skin port.
What's
It's
that?
a one skin port, right? The first one is a jumping technique. First elbow 5, and then you can say use same the skin incision 5S1, and then jumping up back very far. With a small skin incision, we can do 3 level. Next day, patient can go home, right? So under the local anesthetic, we can.
How much of the lamina do you think about?
So the 1 level is just 20 minutes.
Huh?
20 minutes.
20 minutes.
Yeah, it's the total of 1 hour.
So
So
you asked about the lamina, like how much of the lamina?
lamina. So I saw you did this. So you can see that this the right.
It's like a hemilaminectomy.
So lamina is not important. So the more important thing is how can we preserve the facet joint, right? The lamina is not related to the stability, instability post-operative. Right? The jumping technique. What is the 4+2 operation? The patient have a 4 level the central decompression and the 2 level foraminal stenosis with the right? 4+2 operation. First, we can do with one skin port, we can do the 4 level decompression. Right? And then foraminal stenosis, foraminotomy, with one skin port, 2 level decompression. So 6 tray, right? This.
How far can you get lateral in the foramen?
And so we need to check the distance from the midline to the facet joint onto the MRI. Right? Usually the 5 over 6 centimeter from midline. So with the 2, right?
But you got to enter the facet joint to
Yeah.
get to the.
Check. That's right. With the 2 skin port. It's you can do with the 1 skin port, you can do 4 level central decompression, and with this one additional skin port is from the midline is 6 centimeter, right, for this foraminal decompression. Patient have 6 right?
Yeah.
Do you drain every area?
Yeah. It's very important to prevent the post-operative hematoma. And the revision case, right, is water-based endoscopic surgery can distinguish another structure under the endoscopy. It's an open revision case, right? It's very difficult to distinguish other structures. Okay, it's, in case of a motion-caused back pain, we can do the fusion surgery with endoscopy. Structure problem, it's the same as the scope and the drill. So you use the percutaneous pedicle screw and 3D printed porous titanium with the TBM. So like the open surgery, we need to consider how to make the wide fusion bed, and also the lumbar lordosis post-operatively, and the surgical reduction is very important. There's a 4-5 patient the severe instability and post-operative shock like this we can make with endoscopic fusion, pre and post-operatively.
Nice.
Small screens. It's the advantage of the endoscopic fusion surgery. You can do the bilateral facetectomy, ipsilateral and contralateral facetectomy, and then we can insert the endoscope inside the disc space to remove the disc, and we can widen the fusion bed area. It's from the midline 3 centimeter, and we can make the ipsilateral and the contralateral facetectomy. That was
All through the lamina.
yeah. We can reach the contralateral side. So with the small screens we can do it. So operative time is less than 2 hours, but there is no any post ligament complex, right? This endoscope, we can reach the contralateral side to make the wider the fusion bed area. Allowing graft. We can make wider space to insert the cage. First, we have to insert the cage hold, and then we can set the cage loading. After the allowing graft, we can insert cage midline, or to correct the lumbar lordosis, we can insert cage in the anterior space. As a video under the endoscopic view. After retraction of the root, and then we can insert the K wire to retract the nerve tissue, and then we can insert KG. It's a root retractor, K wire. And then you can insert KG into the disc space. It's a L5 traction root. After the facetectomy, we can make wider space. It's L5 traction root. It's a L4 exit root. Like this, the midline, the pre and post operative. Cage anterior placement to correct the lumbar lordosis. Let's insert, and then cage the anterior placement to correct the lumbar lordosis. And always I performed the bilateral facetectomy. The good surgical reduction. Bilateral facetectomy plays a big role in the complete surgical reduction. So complete surgical reduction, the increased contact area between the cage and the end plate will increase the fusion rate. With one skin port, we can do bilateral facetectomy and discectomy and the album graft and cage insertion. And the additional mode 3, the skin port for the just the pedicle screw insertion. All the process should be under the endoscopic view. We can usually shave the album graft. Cage is allowable and the cage insertion. And post-operative, the cross-sectional area.
You do a complete discectomy?
Yes. And the primary restoration is good outcome. And
How do you distract it back?
no, because the usual
How? How do you move it?
because the during the operation we use the large amount of the water will to make it softer all the structure inside, so spine should separate.
The question is how can reduce
Yeah.
spondylolisthesis?
Yeah, reduce the spondylolisthesis.
Yeah.
So we do it once you
Yeah.
fuse it.
It's the bilateral facettum.
So if you increase the disc space
Yeah.
by alignment, reduce a little bit, and with the location of the head, you can reduce the when you do put the rod.
You put the rods in, you have an instrument to do that?
Yeah, it's automatically issued.
Automatic?
Automatically, yeah.
Nice.
Because we they perform the bilateral facettum automatically.
Oh, so it goes wherever you want?
Yeah.
Is it the you're saying that the when you remove both facets, that was what was causing the forward pressure
Yeah.
for the listhesis? And when you remove the facets,
No.
okay, I listen.
So spondylolisthesis, right? There is. Then if you distract the disc space by increasing height, by the alignment being corrected by height, and then with the height of the screw head, you put the rod. If the set screw is bringing slowly coming up. That's
Oh,
what
I
we
see.
use.
Okay.
So it's the outcome. The bone graft area ratio is better than the open surgery. We can make the wider bone fusion graft area in endoscopic view. Yeah. And the disc height and the segment lumbar overseas, everything was better than the open surgery. It's my paper about the comparative study of a bone graft area and fusion rate and the endoscope, between endoscope and the open surgery. As I mentioned, it's very important to preserve the posterior ligament complex during the fusion surgery. This is like this, 1 month later. No back pain because there is no any damage of posterior ligament complex. With a small skin, so we can do everything. So we can preserve the posterior ligament complex. It's in my case, about 75 case, 4-year follow-up. There is no any ASD, right? Because the load on the spine is evenly distributed between the levels. There is a regular ASD, right, compared to the open. We can apply the endoscopy for the thoracic decompression, OLF, also apply to this case. And so compared to the bilateral, the bipolar endoscope, so you can use a two end, right? Two ends. It's very safe, stable, especially in the cervical case. Cervical posterior decompression. It's very dangerous, but it's with a two-hand surgery. Very safe. Also, we use the drill. During the Cadaveric workshop today, I will teach you about this, how to handle the endoscope. In case of a drill, right, it's very scary moment always. But you can use a taposil, and you can get this taposil in the USA, right?
No, it's only in Korea.
The what?
There is a CO phone.
Oh, yeah. For what?
He's going to show that in the workshop.
For dural
it's a-
tears?
During the operation, the Cadaveric workshop, I will show you how to do
How to put
seal
that.
the, yeah. And the bone bleeding, right? So, bone bleeding. They use calcium punch. So usually the bone bleeding comes from the cancerous bone, so we can compress the cancerous bone with the calcium punch. Probably we can
The collective trabecular to control the
yeah.
What are you doing there? What are you doing right there?
It's a Crescent punch.
So he is using the crescent punch to
Yeah.
stop the bleeding,
Uh-huh.
apply pressure.
It's a Korean language. Oh. Oh. Okay. So now endoscope surgery, I think that in Korea, is the must, not option is spine field.
So we got one question.
Yes.
Can you explain the uniportal versus biportal, because there's a lot of talk about the advantages and disadvantages. Can you explain your viewpoints on it?
The first, the uniportal endoscope, it's a very safe the endoscope surgery, and with the one scalpel we can do multiple, right? And with endoscope uniportal can do the HDF, right? So this afternoon I will show you how to perform the endoscope HDF. That's why you should run the uniportal endoscope. Okay, thank you.
Thank you.
This afternoon on the third workshop, right? How to reduce the operation time, the 20 minutes, right? One level.
20 minutes.
Yeah, and the contralateral approach, how to. And the jumping, I will show you jumping sliding technique, right? Vertical, right? And dural repair. And the fusion. Thank you.
Thank you. So we apologize some delaying, some schedule behind schedule, also some changing subject. But however, learning is more important, so we'll change. Next topic by Dr. Cadaveric. He talked about endoscopic and lumbar fusions. This is a new procedure now spreading in the world now. Okay.
Hi everyone, I'd like to introduce myself. I'm Praveen Kadamcharla, orthopedic spine surgeon in New Jersey. I've been doing endoscopic spine surgery for almost 10 years now. And just like everyone else, started with the discectomies and stenosis. We used to do anterior, posterior cervical, and something that I've recently started doing is the intralift endoscopic fusion to take minimally invasive surgery to be able to address pretty much all lumbar pathology. So what is, I know we've covered these topics before, I just want to go through with it. What's minimally invasive spine surgery? Minimally invasive, it's not about the length of the incision or anything like that. One thing that we're trying to present, that we just learned, is prevent any damage to the posterior ligamentum complex. So a lot of people consider it multifidus preserving surgery. And as we know, there's muscle complexes, right, the multifidus, the posterior lumborum. And I think if you preserve the attachment of the multifidus to the spinous process, you really get a chance to preserve that posterior ligamentous complex. And what are the goals? It has to work, number one. It doesn't matter how minimally invasive the surgery is if it doesn't take care of the pathology that you intended to. Less pain, less blood loss, damage to the muscles. If we can do these in a same-day setting and earlier return to activities. So, a lot of different approaches. There's the open approach, then slowly transition to the tubular approach, which is a little bit more muscle sparing, and now finally endoscopic approach, which is truly muscle sparing. But we can only do this approach with help of technology. There's a lot of different endoscopic systems. We're talking about Max Moore. Really, this can transition from an open approach to about a 70 or 8 millimeter cannula, where we're able to work anywhere from 2.8 millimeter working cannula to 5 millimeters for the scoliosis, based on video, and single incision, single approach. And of course, we're using Campion's triangle. The work done by that to put the scope in Campion's triangle. We're able to get this as a safe approach to the foramen and even the lateral recess, using the borders of the SAP, the vertebral end plate, and the exiting nerve root. So what are the advantages? It's minimally invasive. You could do this under a local anesthesia if you'd like. Preserve spinal mobility, preserve spinal integrity, and much faster recovery to regular activity. And this can be same-day surgery and avoid a lot of hospitalizations, a lot of adjacent segment disease. And we're really just trying to avoid doing a lot of open surgeries with its damages. So we go from that open approach to being able to do these with 1 centimeter, 2 centimeter incisions with full visualization. I think that's the most important thing. We're able to visualize the pathology. We're able to treat it directly, much more so than even when we do open. So we're used to doing these for discectomies, decompressions, and then when we needed a fusion, we would switch back to the irregular techniques, the open techniques, maybe an MIS T-lift. But why do we want to go to an endoscopic approach for T-lift when there's an open T-lift? This is a great study done, meta-analysis of 6 other studies with 480 patients. It showed similar complication and fusion rates. Post-operative pain is better, but less intraoperative bed loss, shorter hospital stay, and better long-term functional outcome. And I think the long-term functional outcome has to do more with preserving that posterior ligamentous complex. So what are some considerations when we want to do this? I think we can do this, of course we just saw one where we were able to do this with a grade 2 and 3 spondy. We're able to do this for a grade 1, any kind of instability, lumbar stenosis, discogenic pain, patients with high BMI. To me, this has been one of the biggest changes for endoscopic surgery. A high BMI patient, 35 BMI, trying to do an open T-lift on that patient is a significant toll on the patient and on you, But start doing endoscopic T-lifts. It really doesn't matter if the patient's 350 pounds. It's just as simple and straightforward as it is. Whereas in open, this can add a lot of complexity to do a high BMI patient. And what are some contraindications? For me, grade 1 slip, severe spinal stenosis, but of course if there's severe spinal stenosis, this can be combined with an interlaminar decompression, and then we can go to the fusion. I've started doing some older patients, but in severe osteoporosis, might not want to be doing expandable cages, and if you needed a significant deformity correction, then this may not be the best option. So the basics of starting to do these endoscopic fusions, just like anything else with the endoscopic approach, we're using our targeting with the needle. I always prefer to go in an oblique approach, aim the needle towards the SAP, and usually for L3-4 and 4-5 you're able to do about 35 degrees, and for L5-S1 25 to 30 degrees. And if you're going to do an L5-S1 transforaminal endoscope, it's better to do a much bigger fastectomy so you can get the cage midline. So first thing, my usual workflow with these type of cases is I just like to get the posterior screws part out of the way, use a standard technique with the jam sheeties, put the wires in, and now we're just focused on doing the discectomy. So this way, once we're done with the cage, we don't have to worry about. Start with the same way on an oblique, start with the needle, and I want to end up at the medial pedicle line, and I make sure that I'm past the canal, just any standard safe approach. And then we start with our regular endoscopic dilator, and then I almost always do a foraminotomy. I feel like doing a foraminal decompression is critical. Just going in there, put a cage in, I feel like goes back to the same old technique of just kind of instrumenting patients, just hoping that they get better. The biggest key is with endoscopic surgery is decompression. So first part of the fusion has to be decompression with the foraminotomy, disc removal. And this decompression can also help you with better cage placement. The more medial you can get, the more facet removal you can get a better placement of the cage, get it more midline. And once your decompression is done, now you can decompression is done of the foramen, we're taking out the facet, disc herniation if it exists. Now we're trying to transition to an 8mm cannula in the disc. So the way we do that is standard. Once the decompression is done, I pass another wire through the scope. Now we have direct access to the disc, And this is a dilator system. I'm just going through the one system that I use, which is a Globus rise cage. We're able to go in with this cannula, and then you can remove the outer sheet from your scope. And this cannula is the number 2 cannula. This fits right into the disc space. One of the advantages of these system using successive dilators is we're able to open up the disc space. We're not docking outside the end plates. I want to be able to go between the end plates and make that my working channel. Just like before, my foramen was my working channel. This, I just want to see a superior end plate and an inferior end plate. And these dilators are very good at getting you into the end plate, even in a severely collapsed disc. Slowly distracting so that you're not looking at the posterior margins anymore. They have a nice technique to be able to insert them sequentially and to finally be able to get this 8mm scope. They have a removal system. What's the other alternative? If you don't want to do the decompression, in certain cases, maybe like a 2-3 or a 3-4, you can actually go in with a monitored probe, and that could be docked right on the disc and transition straight into your cannula system for the disc. This is unlikely to work at L5-S1. And this is monitored, so this way you can make sure you're not close to the nerve as you're setting up your dilator system. This could be hooked up to any standard neuromonitoring. So what do? Go with the dilator system. This is the number 1 dilator, and we go in with number 2. And then finally, this is the 8mm number 3. As we can see, we're past the entire canal, and our entire opening is in between the 2 vertebral bodies. So now I'm not dealing with any nerve root at all. All I'm dealing with is disc and end plate. This is a significant advantage to even an MIS TLIF, where you're getting a lot of pass-through. Every time you're using a kerosene, every time you're using a pituitary, somebody has to retract that nerve root out of the way, and there's a lot of traction injuries and irritation on the nerve root. Here, once we've made one path through, the nerve root's sitting on top, there's no more pass-through irritation, and I can confirm here, my inner opening and my outer opening are past the midline. And now we can get to, the disc removal. It's standard. You make an annulotomy, and we have various amount of. The critical part is we have an 8mm fixed cannula. How do we prep the disc? Is this expandable shaper? I can go in with a 6mm, and then I can expand that to a 7mm and rotate my disc. I can go in with an 8. Actually, this can go all the way up to 12mm while I'm inside, and then when I need to take it out, I can redeploy and bring it out.
Dr. Kadimchala, the cage you use goes from 7 to 12, right?
Yeah, it goes from 7 to 12, and if you use an 8, you can go from, if you're able to get a bigger cannula, 8 can go to 14. For most cases, 12mm is plenty. And we have all the disc prep that you would need. We have the pituitaries, called kerosene, rongeurs. Some of the more unique disc prep tools that we have in this set that are very helpful are these. This is the disc reamer. If there's a hard disc or a calcified disc or osteophytes, and you can actually use this to ream an opening into the osteophyte, and then you're able to put your distractors to open up the disc space. And this is very helpful in creating a lot of room within the disc. This is called a disc auger. What this can do is, we have this 8mm cannula, we're going in one trajectory. How do we get disc that's not in line with that? Is this auger is one of the few instruments that can come out of that path and get some ventral disc, and you can actually take the disc out, you can flip it and to do a 360-degree arc with this disc auger. We're able to remove the disc. And we can prep the end plates with our curettes, and also you're able to introduce disc brushes through that to just pick up all of the extra disc and also get some decortication of the end plates.
How far back can you pull the disc auger into the channel?
You can pull it out. So it deploys after you leave the cannula. It goes in closed, and first you face it up, and it opens up, and you get a sweep, and then I actually take it out, and then I flip it around to get the other side. So you're making a complete circle, and that gives a lot of space for the bone graft surface area. And then, you know, we're able to use a lateral X-ray to curette and graft.
Do you only use endoscope or just
So I use an endoscope, then transition into disc prep, and then I go back in with an endoscope again. Then I go back in with the endoscope again to check my disc prep and to check the cannula and to control. So my final step after I'm done with everything is through that 8mm cannula, you're able to put the scope right back in, check your end plates.
How much of the end plate bleeding do you observe, or how much do you?
You can get significant end plate bleeding, but when we put the camera in, it tends to. I try not to be too aggressive with the end plate prep, just like in a regular TLIF for subsidence. And the one thing I realized is, in terms of fusion, I used to be worried about fusion, and I'm realizing my endoscopic TLIF patients are much more stable, much quicker because of the facet removal. We're not doing a complete fascectomy before we do a TLIF. It tends to be much more stable.
So you're basically cleaning out the nucleus pulposa. You're not taking the annulus or anything.
We are taking out the annulus at the entry site, but not. But just like in any other, unless you're doing an ALIF, you're not going to be taking out the full annulus, and you don't want to anyway. You want to contain the bone graft. You need the fusion. And then the next step, once we check the end plates, we can put a trial to measure the cage. It tends to be about 26 or 30mm for L5S1. Anything up 4 or 5 and above, it's either 30 or 34mm. Very much in line with open cages. And through that cannula, the cage goes in at 7mm, and you're able to insert the cage, and you can expand the cage. And you can go, like I said, 22. Usually 22 is too small. 26 is the shortest one that you would need, mostly for L5S1, and then 30, 34 for the higher levels. It's off label, but this cage doesn't support bone graft. But as you guys can see, when it's expanded, there's a nice opening. What I usually do is I take a sheet of extra small BMP, and you're able to put it in there so it's touching both end plates, and it's great now that the process comes in. I use half a sheet of the extra small, and I put a half a sheet mixed with the bone graft pressing anteriorly, and I take the other half sheet. I open the cage, feed it through both openings, and then collapse the cage so that when it's expanded, it will have it. And you're able to put the cage in. I mean, you're going to be within the end plates. You can distract, and then finally you can put the screws. What are the advantages? Definitely less blood loss. It's outpatient. I mean, I've probably done about 50 of these, and the only reason that they would stay overnight is if the case started after 2 p.m. Other than that, there's just no reason. Even 2 levels, they can go home the same day. Faster return to normal activity, easier to handle revision surgery. I mean, if the patient's had a 2-level laminectomy and I'm doing a 2-level fusion, that doesn't change anything for me. I'm going through the foramen, very little scar tissue, whereas trying to do that as an open, high risk of dural tears. And this is another important point, is weight loss does not increase the complexity of this, weight does not increase the complexity. This could be just as stress-free in a 400-pound patient as it is on a 200-pound patient.
What do you do with a high iliac crest?
A little bit more facet removal at L5S1.
Now for the L5S1, do you do an interlaminar, or are you still
transforaminal.
doing a transforaminal?
Transforaminal. I probably did about, most of them tend to be L5S1.
Yeah.
Probably about 25 plus L5S1.
Doesn't that push the cage a little more lateral if you do with transforaminal?
No, started doing a lot more facet removal to
Okay.
get much more medial. Yeah, I tend to be much more aggressive with the facet removal at L5S1 to get the cage midline. Initially I started with the 3/4s, the 4/5s, and now I do 5/1s just as much.
You haven't had problem with iliac crest at all?
Yeah, in the sense that some cages are a little bit lateral. Not every single
Right.
case you can get enough facet removal that you get a perfect center cage. By problem I mean more that the cage is not center.
Do you do 2 cages at this time?
I don't. I usually just do 1 cage. But that's another option if there's a very high iliac crest and you can't get the cage medial.
When you're removing the facet, you're removing the base of the SAP?
Yeah,
or-
you're doing SAP all the way up to the tip. And better visualization of the disc prep, and definitely much less radiation. The instrumentation does have a stop that you can build into it, so that you don't always have to constantly check laterals. And then posterior instrumentation, you can do your standard. This case example is one of my earlier ones where I just started with the 2 3s and 3 4s, and then I started slowly. 59-year-old male, low back pain, right leg pains, disc space collapse. Had a endoscopic foraminotomy many years ago. Comes back with increasing low back pain and leg pain. What do you do? Go in. And this is the key here with the instrumentation is that you're able to get the disc prep cannula in between your 2 end plates. If you can get that between the 2 end plates, it's, in this case, it's already distracted, and now you can pass your instruments through as many times as you would like, and do a curette, disc scraping, and we're able to deploy the cage. And you can go in, usually one for each of the screws, and then the cages are going in two separate, and they go home the same day. One of the ways I think we get them to go home the same day is I always have anesthesia, do an ultrasound erector spinal block for the patients. You can put local, you can put long acting, and honestly, until about 48 hours or 72 hours, most of them are not even picking up their prescriptions now.
Erector
block.
Erector spinal block. So they are basically going in the ultrasound, going all the way down to the last level of the muscle, and injecting, combination of Marcaine with any other.
And you can actually combine this with an on-cue pump. We started doing that recently. You just give the on-cue pump to the patient. And they can, you can do a continuous, and then they can do boluses, and they come back. What we usually do is I mostly try to do these on a Wednesday, and they can come back on a Friday to either get the catheter out. If the patient's comfortable, they can pull it out themselves, and they don't have to come back. But if the patient's not comfortable, most of them just want somebody else to do it, even though it's simple. They come back to the center on Friday, and the one thing we can do is we can redose the block at that time. So now they have another 48 hours of pain relief, and then take the catheter out. Or you can always have them on Monday. And this is very typical. Patients are going home. This is literally 4 hours. That's in the PACU. This is the patient that had a 2-level. The patient that had 2-level. It's that X-ray that we saw. And that's him.
He's got a foot drop too, huh? Oh, no, he doesn't.
No.
I thought that was a break.
No, I just got this
He's
sock.
got to fix his sock before he goes home.
And the key points are, I'm going to show this in the lab. The needle placement is key, because sometimes when you're doing a scope, if you're a little bit off angle, it's perfectly okay. You can always, rotate your camera. But in here, because you're dictating the path of the cage, you need that to be perfectly in line with the disc space, because if the cage gets deployed at a different angle, that's when you're looking at subsidence, breaking the end plates. So I always make sure the needle is perfectly in line with the alignment of the disc, because once you do this part, you can't correct for that later. As much as you want to try to correct it later, it's just not going to happen, and the cage is not going to go in properly. Must visualize and retract the exiting nerve root before inserting the dilator. Discectomy and disc prep are very similar to the MIS TLIF, except no nerve root retraction. You don't need an assistant for it. End plate prep can be visualized. I think you should do a lot of transforaminal endoscopic, especially outside in, before you do this, because you need to be able to do a good fascectomy. You need to be able to visualize the nerve root and make sure it's retracted away before you set up your dilator system. Once you're comfortable doing a fascectomy and retracting the nerve root, then the cage insertion becomes simpler.
Any questions? Great talk. Let me ask you, what do you think? What's the ideal patient for this interval, if you think? Because many patients, severe central stenosis, probably you're not going to do interval, right?
Yeah, I think a moderate stenosis, radiculopathy, disc space, and for me, it tends to be high BMI. High BMI is what I'm always trying to think. I'd rather do this than than to do an MIST lift or an open. And I think, honestly, you can combine this with interlaminar decompression, and I think almost any T-lift.
For the more than grade 1, you mean the grade 3?
Yeah, so I would do a grade 2 or 3 if they're correct. I would correct first. For me personally, I put the screws first. I reduce. I leave the top screws a little loose, and then I do my cage.
The first, the bilateral facet.
Yeah, bilateral fascectomy, and then I do the reduction first. I always put both my screws, lock them lock them inferiorly. Then I do my cage.
I do if grade 1, I just reduce.
Yeah, grade 1 you do.
Grade yes, 2 and 3, yes, yeah.
Yeah, reduce first and then put the cage in after. That's
right,
mine.
right. Yeah. Thank you so much. Okay. So next speaker, Dr. Jasper, regarding interspinous and interlaminar fixations.
Who was it? What am I doing?
Minuteman.
Interspinous
fixation. Well, I'm Gabriel Jasper. I've been doing this probably pushing 20 years now, endoscopic surgery. I've been all over the world. You know, I started this because we had so many big, major, unnecessary spine surgeries, which is still going on today. And in my practice, I tried to avoid it. So I found out that you can go to Korea. I've been to Korea twice in Seoul with Sang-Ho Lee, Gun Choi, good friends of mine, and we constantly keep in touch. I've been to France, Germany, Holland, South America, all over the United States. Everybody doing. You're the only guy that can go see it. But anyway, I'm an avid believer and always will be for endoscopic surgery. However, with the evolution, we have to have an open mind with the evolution of what's going on today. There's always somebody down in their basement trying to figure out ways of doing minimally invasive surgery without to avoid big surgeries. And I still do quite a few endoscopic surgeries. I do the surgeries for any pain generator that's touching a nerve is going to cause you to have pain. And what you need to do is not only know how to do endoscopic surgery, you need to know how to diagnose where the pain is coming from. You can have a person with a 4-level neuroforaminal stenosis, and a lot of those patients don't have pain generators coming out of those 8 different holes. It's usually 1 or 2 holes, and most of the time it's just one neuroforamin that you can isolate with certain types of injections with selective nerve root blocks and find out which one it is, and you go in and you treat it. But I like to talk a little bit about the posterior interspinous spacer, which has actually dramatically decreased the amount of endoscopic surgeries that I do. And the reason why is because if you think about the anatomy, and I'm not preaching to anybody that doesn't know what's going on here, but everything that we deal with is because of degenerative disc disease. When you have degenerative disc disease, you got the disc which is now closing the neuroforamina. It's closing up the lamina, and so you're pinching the nerves coming out. You're folding the ligamentum flavum, which is putting pressure on the central canal, and you're putting a lot of pressure on the facet joints, which now are becoming hypertrophic and they're occupying space, right? So what's a good way to treating that? I treat endoscopic, but endoscopically, if I got one patient with 1 neuroforaminal stenosis, no central canal stenosis, maybe a herniated disc, some osteophytes coming out of the end plate, or osteophytes coming out of the facet joint, I'll go in there and do a foraminotomy, I'll take out the herniation, and all the sciatica pain goes away. But then you have patients that have central canal stenosis, right, ligamentum flavum, foraminal stenosis, facet joint hypertrophy. And what I found is by distracting, these are the people who sit down with central canal stenosis, they have sciatica pain too. It distracts the central canal. I mean, it distracts the spinous processes, and what does that do? It distracts the neuroforamina, it flattens out the ligaments, and decompresses the facet joints. And these patients do fantastic. And I'm talking 5-10 minute procedure, brainless. I tell people, doing endoscopic surgery is like rebuilding a motor, right? doing a facet, doing an interspinous spacer, it's like changing spark plugs. You know, it's a no-brainer. There's no stress. You know, you just do it. It's a very simple procedure. You come in from the left side. You know, you count what level. You know, of course, you got to know how to read the MRIs and figure out how to clinically do it. But you find out what side, what level is the worst level, and you make a little incision, maybe less than an inch. You know, maybe a centimeter, and you go in with a wire. And you aim for where you're supposed to go. You stop, you go AP, and you stick the wire across the interspinous ligament. And then you do sequential dilators that just reach the facet joint. And then you go in with a measuring device, and you measure what size you need based on the tension. And then once you do that, you go in with an instrument that puts this in, it deploys it. You screw it in, and you also put some DBM in there also to enhance the fusion a little bit, and you're done. You're done. And the patients get off the table, and I have videos of these patients getting off the table who had wobbly legs, severe low back pain in the buttocks, radicular pain. The radicular pain's gone, right? And now they're walking, and they make statements like, "My legs feel 30 pounds lighter. My legs feel stronger. I don't have that vice grip around my legs anymore. I don't have that low back pain. It's gone." I mean, that's what it's all about. And when I started doing this, I was going to conferences, and I've done probably more than anybody has in the universe on these spaces, because where I live in Toms River, Bricktown, there's a very high population of Medicare patients. Now, if somebody asked me, did I ever have a failure with this, as far as radicular pain, you know, low back pain? No. And they say, well, what happens if the patient still has sciatica pain? I make a little 4mm incision, I go in there endoscopically and open up the foramen. To me, that's not a failure. A failure is when I got to send the patient to a major spine surgeon who does major spine surgery. So, and also, if sometimes the ligament is so thick that it might not work, I might go in there as a prerequisite and go in there and do a mild procedure and take out some of the ligament. It almost guarantees that the spacer is going to work. And if it
how thick of a ligament what's your threshold for doing mild and then putting the spacer in?
Well, if I see somebody with severe spinal stenosis based on thick ligament, right? Then I'll go in there with a mild procedure and I'll decompress as much as I can. You know, a mild procedure, they go in 3 times, a couple times, and they take it out. I go until I don't have anything coming out anymore. And then I go in and put the spacer. But if I see a mild to moderate with neurogenic intermittent claudication, I'll just go straight to this. And it's like a 98% success rate.
But why, if you decompress the ligament and you think that's the reason for their stenosis, why do you put a spacer?
Well, that's what decompresses it. Because if you think about it, when a person sits down, this opens up, right? They feel good. Why? Because the ligament is like a leather belt. Do you ever have a leather belt and fold the leather belt and you snap it? Right? That's when you sit down. You put the belt together, it forms a loop. So these people are the kind of people that when they stand up, this collapses, right? It folds it like a leather belt and it starts putting pressure. So when you put a spacer in it, it keeps it virtually in a sitting position and flattens out the ligament. Now, we know that you don't need to take out much ligament, even open surgery. A lot of these guys that do flavectomies with little hemilaminectomies, they don't take it all out. They just take a little bit. So if you think about how these people respond with a little bit coming out, you don't need much. And it's amazing. Like you got patients coming to your office, you look at their MRI, and it's completely closed down, and they walk in with no cane and no walker. And you're like, how the hell do you walk? I call them a phenomenon, these people. And then and they say, well, I don't know, I got no problem, I can walk wherever I want. And then maybe 3 months later, and I told you about it, 3 months later, they can't walk anymore. I say, Doc, you jinxed me. And the reason why, and then you look at the MRI, a new MRI doesn't look any different because it might have gone from this to this. I call it the critical point. So you just distract them a little bit and they're back the way they were, walking around, say, hey, thanks, Doc. I hardly have any pain to go home the same day. I mean, so it's eliminated a lot of my endoscopic surgery. I love doing it, but you got somebody with two-level foraminal stenosis, central canal stenosis. How are we going to treat that? I mean, if you want to be a true endoscopic surgeon, you have to go intralaminally take down the ligamental flabum. Then you got to go both sides and take down and do a foraminotomy on 2 different levels. I don't know about you guys, but I don't like doing that anymore. When all you have to do is put a spacer in and open it up and the patient's happy.
I think one important concept is the emphasis is the anterior epidural space, right? Ultimately, I think the outcome is because if you're comparing posterior versus, you're opening and addressing the anterior epidural space, just like transforaminal and interlaminar. So
Well, partially you are, but also posterior.
Yeah.
The
also
ligamental flabum.
Right, but I just think from a pain standpoint that it's effective because you're addressing that anterior portion.
So, all right, so that's a 4th thing.
Yeah.
Neuroforamina opening up, the ligamental flavum,
Right.
distracting the facet joints. So now I can say you killed 4 birds with 1 stone, and you're distracting the annulus
Right.
to a certain extent.
Now, what's your choice of picking this over your Vertiflex?
Vertiflex?
Yeah.
Well, I mean, Vertiflex was always good. I still today, I haven't done it for 5 years, probably done more Vertiflex than anybody in the United States, or probably in the world, right? But the reason why I do this is because I think, and I don't want to talk about this. I'm here. Really, I'll talk to the side. I don't want to talk to you about different industries. I'm not here to knock anybody down. So later on, I could tell you about that.
So we have to cut it short because
That's no problem. I got my point out.
Just one question, I'm sorry. Okay? So X stuff we used in the past because they failed because long-term outcome was kind of bad. What's the difference with the X stop?
Well, the difference between X stop, the problem with X stop is slipped out. Other types of interspinous spacers slip out. They come out. You can tighten that up till you can crush the bone, but of course you don't want to do that. And you have DBN, that goes, demyelinating cortical bone, that actually grows into the bone. Because there's a hole in the middle, I don't have one in front of me, but there's a hole in the middle that grows from one side to the other. The what do you call it, the titanium. So, and more than 500, pushing 1,000, and I have never had any of them back out. You know, in fact, I put it out where the initial ones, the whole back part would fall out, and now you in perfect. And why? There's another reason why I like this one, because you don't.
I have a video. Well, no, I don't need to. Yeah.
Okay. Let's
Do you think maybe we can take like a 5-minute break?
You can go. You can go.
Okay.
No, Dr. Lim can present because we have a after this.
You can prepare in the meantime. Okay. So there's a chatting site is open, so let us know.
about the cervical case, how to solve the problem in case of the cervical case. So anterior, posterior approach goes right. So same the endoscopic can try for the cervical case. And we use the case punch and the drill. And it's a cervical case, right? With endoscope, the operation will provide good, clean the surgical view. It's motor and the sensory group. And we can apply the endoscope surgery for the cervical decompression, discal remove, paracentral type, and foraminal discal, and the stenosis, the central canal stenosis for myopathy and the foraminal stenosis. And you can use the endoscope for this HDF and classify the huge disc and also the C1 to high cervical region. So I think the endoscope surgery for myopathy can be another challenge that we have to overcome this the cervical myopathy. So you know very well that the symptom of the myopathy progress when you will change the weakness and get change. Right? So we have to check an MRI. And how about the operation for the myopathy? We are doing the vehicle, the open surgery, the posterior approach laminoplasty and anterior corpectomy and vehicle operations for the myopathy. And there is the endless constant debate for what is best way to anterior approach and posterior approach for myopathy, always debate session. But we have another the option, right? Endoscope. Right? So we must be the endoscope, the decompression or HDF must be added in debate session always. Right? So like this. So what is it your choice? Microscope and the tubular. And I think the endoscope is better than any the operation because we can preserve the lumbar structure with the clean surgical view, right? Okay. So it's the endoscope will perform the either the posterior and the anterior approach for the myopathy. It's endoscope surgical view is very clean. It's decompression for the spinal cord, anterior HDF. And in case of myopathy, I recommend you show the check the dynamic MRI. Quite different. The MRI shows in extension flexion. So in extension, the MRI that shows the main pathology is posterior, located posterior. Right? That's why we can decompress this with the posterior decompression. So if the location is the posterior located pathology, we should first posterior decompression first. Right? With the endoscopy, I think you will try to the laminoplasty in case. But with the endoscope, it's pre and post-operate, right? With this we can do decompression endoscope. Right? With the one scaffold, we can do multiple levels. With endoscopy operation, we can preserve a posterior complex. That's why, in case of the multiple level the decompression with the endoscope, during the follow period, there is no any type of change. And yeah, we can laminoplasty can be avoided. And the cervical, the muscle is very important. Plays important role in the motion the stability that allows the weight to be supported 5 or 6 kilograms core. So with the endoscope, just a small the muscle damage is required, but the open surgery and some of the bipolar endoscope had to sacrifice the muscle damage. So it's the case. It's just a foraminal stenosis, foraminal disc with endoscopy. You can decompress root is a motor root, the sensory root. It's a disc space. And then in case of disc herniation, we can remove a fragment with endoscopy. Okay. And the patient have L34, the biped, so with the endoscope, we can decompress from
We dissect down the facet joint.
facet. No, it's at the central,
Interlaminar?
central the decompression. So from the ipsilateral to contralateral side endoscope. So without damage of posterior decompress. One level, pre and post operative. Okay. And the two level patient have about 230, 34. The and the 3 level, the patient have 3 level stenosis. The actual MRI shows also narrow space of spinal cord. What is your option is a pre and post-operative like this, and the actual dose with one skin fold. But we can preserve posterior complex. Right? So with the endoscope, it's sliding tape, 3 level with one skin fold. Right? So it's this video shows the central decompression. First the CF34, sorry, CF34, the 4-5, the 5 and 6 from the ipsilateral to contralateral side. You can decompress. Right?
How much of the lamina are you taking out? How much lamina are you taking?
Lamina, right?
How much?
Yeah. It's just for the ipsilateral to contralateral full decompression.
Oh, full.
Without damage of
What diameter is that?
It's the same.
Same,
it's the same
same
center.
scope.
Same
Same
scope?
scope.
Yeah. Okay. Yeah. 30, 34. From ipsilateral to contralateral.
That's amazing.
Yeah. For spinal cord decompression, right? So we can avoid the big operation, laminoplasty.
Okay.
Yes? In the 4 level. 4 level. And the actual pre and post-operative actually. And this is the high cervical. We can apply the endoscopy surgery for the high cervical. See, 1, 2. I have the 6th case only because it's very, very rare in Korea, C1 region. So the first time when I tried this the operation, it's very scared me because no any difference about this. Right? So I didn't realize how to approach the C1 region endoscopy, and the water effect on brain. There will happen the brain swelling and ischemia, right? And there will happen the damage of the spinal cord injury during the operation, and we have to know the course of vertebral artery, the instability post-operative. So we are very, very familiar with this operation in the fusion surgery in case of C1 region. But there's some paper published in case of small the ADR, it means the mild instability in old age high risk recommend just the decompression C1, the hemilaminectomy. It's open surgery, but if we can try to endoscope this operation, so we can preserve the approach. Okay? So, but we have to check out the perioperative CT angio to know the course. Just beside the spinous, just beside the vertebral artery. That's what we have to check the course of the vertebral artery is very important. Right, the landing, right, the C1 region, and this video. It's a C1 the lamina. Then we can punch out, and the final, right, it's a C2 root. And it's brain. Screen first.
We'll leave it up to your expertise.
I'll send the patient to you, doctor.
But the 6 case, there is no any the brain problem.
So
So, but you're not able to get to the disc, right? You're just doing the posterior.
Posterior.
Yes.
So this one, well, first landing point is C2, right? And then
Wow.
this well, it's anterior transverse ligament, right? Okay, right? Landing point is here, right? C2, and then we can reach to the transverse. It's a panels formation we can remove. After that, we can reach to the anterior, the transverse process. Then this go. Okay. Free. Post-operative.
I mean, do you change any of your settings for your bipolar when you're doing this at the high levels?
No.
No?
What is your bipolar usually set to?
He uses a different
The
bipolar,
quarter-
so his
the
setting
quarter.
is
Oh,
like
yeah, yeah.
about 40 to 60 watts, right? For your bipolar? 60 watts is what he uses.
Even for
But
that,
usually I use the
He's high power, he's
high,
good at.
yeah.
He's got a philosophy, he does short
Your
bursts.
max.
That's
high
in a
power.
short time. This one. It's a pre and post operative, right? Maybe like that.
Oh, you got those with monocle. Why staples?
He's in a rush.
It's
No, the patient
tired.
stays in the hospital there.
He got tired. He was
The
hungry.
patient stays in the
It's a
hospital
post
overnight.
operative. The
So
X-ray
that's why,
for-
you know,
shows
That's
they can
post.
call this
no
post-operative.
any change or what is not instability post operative.
So that's
what-
the other nice thing, they do post-operative, images, which we can't do here because most of the time.
No, what do you think about this? The central huge disc.
You go anterior.
It's impossible to, right, with the post operation to decompress this one. So that's why we have to anterior approach, right? Huge disc. So it's an endoscope HDF. It's advantage this operation actually provide good visualization, very safe, and operation time is around 1 hour is enough. And MRI shows a post-operative anterior the soft tissue swelling is very low. That's why it's endoscopic discectomy, and we can remove the PLL and the post-osteophyte.
You keep TPLL in there, right?
How do you exit the anterior? Because most of the time you're afraid to push this herniation in. So what do you do to prevent this herniation from going in the canal?
This is the
I'm not sure which question.
The problem with, anterior cervical discectomy is you're going with the actual dilator, right? And you're afraid to push for this herniation to go in the canal. So how do you prevent that?
So you direct 넣었을 때 디스크가 푸시되는 거 같아요. Because the aneurysm is
Not worried
carnal.
about
I don't
He
think
takes
it's
it out,
causing problems.
it takes it out slowly until it comes in.
Also,
right?
dilator is larger than disc space.
it's
There's no-
different
there's no-
because
It should happen.
during the operation, it's a water-based the operation, right? It's a different like to open the surgery. So during the operation, water will
So how do you get access to it? Needle, right?
needle,
And then after the needle,
and then we use the serial dilator.
and then you stop only at the anterior annulus,
Mhm.
or you actually put your dilators to go inside the disc?
No, you don't need.
So the dilator is outside the disc space.
Yeah,
Outside the disc
outside,
space.
right.
So you open the annulus
Mhm.
manually,
Mhm.
and then you search inside
Mm-hmm.
the disc. You keep taking
Yeah.
the anterior disc
Mhm.
until you get to the posterior
Mhm,
disc, right?
Mhm.
It's actually, that's actually the easy way of doing it. You know?
Okay, so. Yeah, after
So the
weight-
cage you use is the same cage?
Same
or-
cage. Right?
Same cage.
Yeah, same
okay.
cage. Right? It's endoscope, right? The small screen. The same scope. Right? Using the endoscope, we can.
Those go from the right side a little bit, or you go pure anterior?
Depends on where the herniation is.
No.
You have to be central, you have to really go down straight.
To check the first the MRI, the esophagus location of the esophagus. Okay, anterior visceral esophagus, because I think the scary moment can be the visceral anterior.
What?
Yeah. the
Esophageal injury.
esophageal injury.
Esophageal injury. Esophageal.
The postoperative, the shows cage.
So you're not using plate or something, right? So have you ever seen any non-union dislodgement of
No,
the
there is
cage?
no. I don't use the plate because before the performing the endoscopic HDF open surgery, that's just one level. I didn't use the plate, only standalone the cage. The paraphernalia space. My case is most common site was 5 or 6, and clinical outcome include recovery rate. It's myopathy recovery rate is and some the radiological finding outcome was very good, and fusion rate. We can check the bone bridging with a CT scan or the X-ray. The first cage holder for insert cage, and then you can set the cage, and you can use the 2-blade literal system. And before the implantation, you can see the dural pulsation, right? After you remove the PLL and the uncovered joint, and then we can insert this cage. It's just a 1.5 or something. It's, as told, it's very important to check the dynamic MRI, right? Flexion, neutral extension, narrow space. So with a finger, you can push the anterior organ to the upper side. Before the operation, it's very important to insert the Levin tube, right? L tube, to know the location of the esophagus, right? And then with the finger, push the anterior organ to upper side, and then we can make the space. First insert the needle, and then the serial dilator, and then you can set the endoscopic stem, and then every discectomy you can insert the cage like this. Right? It's space, right? Anterior space and discectomy. And to remove the posterior osteophyte, we have to use the drill, and that we can remove the PLL and the discal. The final we can find the dural pulsation.
The drill is the same drill?
Yes, no, it's a smaller one.
What's the tip size?
It's at the 2.5.
2.5.
You say you're removing the PLO?
Yeah. The dural. That's the post-operative, right? And your the right side to left side. The first the MRI to find the esophagus, right? It's located at the left side. That's why so approach is right side more parallel than the left side. That's what to know the esophageal location. So we have to insert the Levin tube first. Okay? There's a Levin tube, and push the 2 finger visceral organ to the upper side. But the finger will be exposed to a lot of radiation, so I'll change it. Today I will use this rifle technique. Instead of the 2 finger, you can use the obturate, because obturate inside has a small hole, and then we can use this the obturate, and then we can insert the small the wire, right?
It pushes everything to the side, right?
Mm-hmm. It's a landing point. Yeah. Between the esophagus and this carotidus, and
So it's pushing the carotids away instead of in between.
yeah. And during the operation, you can use a lot of the water where to make the space water. Right? Okay, it's very important. Also, the final stage we need to keep the drain to prevent the post-operative hematoma. So, the case is right arm increase C45 myopathy, and so actually MRI shows you the big disc. This what is a calcified disc, right? It's a disc shows. That's why we can do anterior for the same way. The first insert the needle and then the instrument, and then we can remove it. How about this? Very important. MRI.
Where do you keep the drain?
Okay.
How do you put the drain through a scope?
Just under the endoscope, you can, you know, under the endoscope you can insert the drain. And I told the dynamic MRI is very important, right? Dynamic MRI shows we have to decompress the first, the posterior decompress first, and then we have to do anterior posterior decompression and anterior. Yeah, pre and post operative. Posterior decompress first, and then we can do anterior approach HDF. Right? And female, the old female patient, the right arm pain, C5, 6, 5, same way, we can do pre and post operative. And 80, male patient, the C3 myopathy. The epididymal is just less than 5 mm. Right? So locate the pathology is located posterior anterior. So that's why we have to first the posterior decompression and the anterior HDF.
Do it at the same time?
Yeah, same time. Wow. Yeah.
How was that patient pre-op? I mean, the MRI is pretty impressive.
Yeah. So the myopathy.
Had no proprioception.
Yeah. The walking gated destroyed.
They don't know where their feet are.
First the posterior decompression first, and then anterior the HDF with the endoscope. So X-ray shows right, the posterior anterior the true drain. First the posterior decompression from the ipsilateral to contralateral side, the spinal cord, and before implantation you can see the dural pulsation, right? And then we can insert the cage implantation. Endoscope. It's my paper about myopathy. Case of the myopathy fold with endoscope HDF, and we can apply the ADR also, same way under the endoscope view, right? So we can apply the endoscope posterior decompression and then HDF, so you can try. So it's not easy, but I think the development instrument and some the instrument, so that anyone can do this operation.
What codes do you use for that?
He's great.
It's good.
Great. Oh, you don't do it here?
Yeah.
No.
You do it here?
Yeah.
He's from Korea.
I know, but what codes do you use? You get paid for that?
You should hire me.
do you get paid for that?
Korean treatment system, they do surgery first.
What?
They do surgery first, then they ask the reimbursement.
The other way.
So thanks so much to all of the speakers today. A lot of the good that what's going on in the endoscope world. Any question regarding the last talk, Dr. Lim? Dr. Lim, let me ask, what occasion you avoid percutaneous, as a neurosurgeon kind of okay? If you went with one case damage at carotid artery, one case is so what condition you just, oh, I'm not doing percutaneous, I just open surgery. Any?
So most of the scale could be the anterior organ damage, right? So first the trial In case of the short, the thick the neck, it's very difficult.
Because you can see lateral X-ray.
Yeah.
So whenever you have a lateral X-ray, you cannot see shoulders here. You cannot.
So whenever I try to now it's okay. But first time I tried this endoscope, the HDF, it's always my heart rate was increased. But now it's okay. That's why I will develop some instruments so that anyone can do it.
So he has enough gut to continue this kind of procedure. I cannot. At least. Okay. So thanks so much for these sections. Okay, we're going to Cadaveric.
Yeah, so there's a, just to get everything changed and all, there's like a 15 to 20 minute break. Everyone feel, free to change. And then we'll move into the cadaver section. We're all set up there. Yeah, we're done.
So we started open chatting. So any questions to send us chatting? You can ask the
I think
speaker.
there's actually a lot of responses coming from India. I mean, people are, like globally, a lot of people are commenting. So
Okay.
people are watching.
See you soon.
So there's a little longer room there. You can change there or you can change the measure too. Yeah. Yes. So we're done, right?
Should I stop it?
Here you can.
What time we come back?
So I will. I will
This
make
is
a motion.
11:07 in the Eastern Time in the United States.
Yeah. So
Okay. We're back around 11:20 Eastern Time in the United States. 11:20.
Is that 20 minutes?
Only
No, I
11:20.
didn't hear it.
he's the magician.
Done.
But it was wonderful. Thank you for the very nice presentation. I think I really enjoyed the talks.
If we do anterior cervical discectomy, they're waiting. They
Sorry.
consider it obsolete in this country.
Yeah.
So I did a couple, so.
So we need to connect to the water irrigation wall.
There's no more.
Water irrigation. Oh, here. It's irrigation pump.
이렇게 되나?
이것도 어떻게 연결하지? 준비가 안 돼 있어.
There's no more.
이거 반대지 않나? 이거 않나?
뭐 3회 되면 뭐 충분하죠. 네, 저거 펌. 줄일 발판 한번 밟아주시겠어요? 오케이. 열을 댔고. 시험이요?
발판 있어요.
요건가? 아, 이거네. 씨. 요건가, 그러면? 물이 없어서요.
다시 해보세요. 홀 들어오네. 됐다. 이거다.
And I'm going to connect the camera. Camera is connected yet?
좀 더 이게 나.
Press the white, there's a white down button there. Yeah.
세대. 됐네.
Now press the white.
Yeah, I know.
이 물이 흐를 텐데 이 바닥에. 이 바닥에 문제될 텐데. 와, 줄줄이 흐를 텐데.
Just so they can see what I'm saying.
뭐를? 그래?
Right, please, we're starting.
Sound check. Yeah, check again.
Okay. Hi, welcome back. I'm sorry, a little delayed the setting up the cadaver. So Dr. Lim will show posterior lumbar decompressions. Dr. Lim, start.
Okay. For the posterior approach, the first so landing point is very important. So the CM is just the check lateral view enough because the landing point is just beside. It's a spinous process, right? Just beside the spinous process. So that's why we don't need to check AP view or lateral view. Right? Okay. CM check. No. I try to L45. CM check. Okay, you're right.
Would you like a better position?
It's a patient that does the scoliosis. Scoliosis.
It's good for you.
Yeah. And then
It's like a better, it's not a great image.
no, it's okay. Yeah. Wow. Okay. Some check. Okay. Just beside the spinous process.
Making a incision just beside the spinous process.
The mosquito.
Okay.
So, using. And then. Okay. What you say?
So we bring dilator now.
And the walking sleeve. Okay. Insert. And then some check. Yeah. Some check. Okay. So. And then.
Where do you want your ideal placement for the cannula in terms of the lateral image?
It's a patient of the scoliosis. It's very difficult to landing, but for first, you should try the landing on system. It's a lamina. It's okay, more. Some check. It's an interlaminar space, right? It's interlaminar.
So you want to be targeting the interlaminar space?
No.
You want to be
on the
targeting
lamina. On the lamina
right?
first.
On the lamina. Okay.
And then I will try to the tilt
Can you
line.
go down to the
You
X-ray?
gotta raise the table like an inch, please.
Okay, so where's the control? It's with you. Right there.
You're bothering me the whole time. Excuse me, down.
Okay.
It's going to raise up a little bit.
Okay. Stop. Yeah. Okay. It's a lamina, the interlaminar space, right? Lamina.
So interlaminar space, you want to hit the spinous process or just middle of the lamina?
Yeah.
Spinous process?
Because the first the system that should be the landing the lamina first, right?
Lamina first.
Lamina, not the interlaminar space.
Okay.
Because if you try the landing the end of system the interlaminar space, the first we have to reach to the final destination is the uppermost ligament flavum.
Okay.
From here to, if you want, we'll try to the interlaminar space. Very difficult to reach the uppermost ligament flavum, right? That's why first on the lamina.
So on the lamina, you want the lower
And then
lip of the lamina, or you want the middle of the lamina?
Middle.
Middle of the lamina. Okay.
And then tilt like this.
What's the medial lateral point? Like, middle of the lamina or medial portion or lateral
no.
portions?
First landing is on the lamina, and then tilt.
So middle point of the lamina.
Yeah.
Okay.
And then you should laminotomy, and then you can reach to uppermost ligament flavum, right?
Okay.
Sham check. It's a lamina. Sham check. It's an interlaminar space, right?
We have the drill. We have the drill going. We have the drill.
Some water.
Water is the
Okay.
pump on.
The pump is on. Pump is on.
It's okay. Right?
Sorry.
Okay.
What to do?
Get some punch. Get some punch. Two
You have your punches.
2 million. The forceps.
Forceps. Pituitary forceps.
The first you should remove. soft tissue
You're
on the
down here
lamina.
on the lamina?
Yeah.
Yeah, lower lamina.
Lower lamina.
He doesn't check an AP at all. He does everything on the lateral view.
Yeah, exactly. Because it's location.
Oh, nice.
Yeah, it's a lamina, right?
Yeah.
It's intralaminar space.
Not too much bleeding.
So first, you have to find the spinolaminar junction, right? Spinolaminar junction. Can you turn off the right? Yeah.
They take out the dead tissue, stuff that's not good. I mean, it's dead.
It's lamina, interlaminar space, right?
I understand.
So punching, we can.
Lamina, it's a lamina.
Yeah. It's a spinolaminar junction, right?
That's
Yeah?
the,
Nice.
is that the superior inferior lamina?
That's the superior. That's the superior lamina. You always
It's
go
a L,
superior lamina.
it's a L4 lamina.
Medial to lateral. You will go all the way lateral.
L4 lamina, right?
Then you go cardiac.
Can you one more time in orientation? Which one is
Okay.
the supinous process? Which is the cranial
Yeah,
cauda?
it's a spinolaminar junction, right?
Yeah.
The 12 o'clock is a spinous process.
So the supinous process.
Yeah, yeah.
Okay.
6 o'clock on the screen.
And then
It's the spinous process, right?
spinous
It's a
process.
facet joint, right?
so the 6 o'clock facet joint.
Facet joint.
The 9
It's a-
o'clock is the cranial.
Yeah,
All right.
cranial here, right?
Thank you.
Beautiful. Can you save the picture?
Yes, sir.
Okay, please.
Actually,
Okay. Right. But it's very difficult because the patient have the scoliosis, right? Skull change. So you can see what is inside.
Do it fast.
Yeah, you got the flavor, right?
Release some light.
All that light packets in there.
And then you can use a drill, right? Drill. The punch is not available. We can use a drill. So with it's so this the finger is very important. Will act as a stopper, right? Like this.
What is that?
Stopper, right?
Oh, to stop.
Stop, right?
not for the going.
Not yeah.
Let's stop.
Do not
stop
use
your
it,
finger. Your
the
finger
drill like
control
this.
is
Oh,
the
with your
depth.
finger, yeah.
Dangerous, right? In case of the cervical case, dangerous. Inside the foggy. So you use drill like this.
Taking down the lamina and some of the facet.
Yeah, and then the eye.
What?
Okay, lamina. So we have to reach to uppermost ligament flavor. So should be careful not to damage the facet joint.
Is that a diamond ball?
It's 3.
The ligament right there?
But it's still lamina, drilling, intercortical lamina.
It's very difficult because patients have the scoliosis and the tropism.
Six is lateral, right? 6 o'clock is lateral.
Yeah, facet joint, 6 o'clock.
So how far do you go before you're gonna start chewing out the
Just beside the spinous
eye-
process.
the
That's it.
Oh, it's a very severe the scoliosis. anatomical structure change. Okay, carry some points, please.
Both sides.
Two
or four, three.
Yeah, ligament
Which
flap
one?
two, please. 갑자기 또.
So now they're removing inner cortical bone of the lamina. After this removed, you can see the ligament flavum.
Oh, that's right there. It's cortical.
Wow. This is scoliosis problem.
The yellow thing is a ligament flavum. Ready? Ready?
It's still unmovable.
음악 시계도 트로피죠.
Still does it.
Yep.
Look at what's right underneath it.
Okay, and drill again. Yes, I recommend the 4 millimeter, the diamond drill, but it's too small.
Which one is that? 2 millimeter?
It's 3. Yeah, so 4 lumbar 4, yeah. Okay, 2 millimeter punch. It's inside.
Wow.
스콜스 너무 심해가지고 정상적이지 않아. 아, 왜 그렇지? 자, lamina.
Okay.
4 millimeter punch. Yeah. Closer, please. Okay. 2 millimeter punch. Reverse. It's a 4. Oh, it's very difficult to find the anatomical structure because severe the scoliosis inside. 2 millimeter punch. 어떻게? 큰일이네. 근데 지금 아나토미가 완전히 문제가 생겨서.
엑스 한번 찍어볼까요?
예, 시험 체? 예.
In the lens, that's why it is hazy like that.
It is?
So Kevin, just open the camera.
렌즈 안 닦았어? 잘 안 보이죠? 네? 렌즈 안 닦았어.
So it's foggy inside.
No,
Yeah?
there's water in there, that's why it's so big. Can I help? And then there's probably water in there, that's why it's,
It's the foggy.
yeah, the connection really gets weak. And then clean that part.
Get better.
Better now?
Yeah.
Open the irrigation.
오케이.
오케이. 이게 지금 아까 그게 쳐져서 그런 것 같은데. So
Yeah,
wet,
give it more dry.
dry.
Yes. Dry.
Dry.
Good. Now real like a right take. What? You can use this one. No?
No, that's going to be...
More worse?
Yeah, so can I give you more and I'm going to get the
Make sure
big...
this is now absorbing properly. This is where
Water gets in there. Please get in the camera.
Okay. Okay. Better. Water.
Water on.
Okay. 2 millimeter calcium punch. 2 punch.
So where are you working now, Dr. Lim?
It's laminar. Right? Oh.
Is the water not sucking?
the water is now sucking. Hey, check the suctions. It's disconnected. Stop it. Stop
It's
it.
a big problem.
The other one.
Severe
Oh, yeah. Sorry.
water.
That's obvious.
It's sucking or not?
Oh, we need to change the
Suction is not working. No, suction is not working at all.
Suction. No. It's a problem. We need to solve a problem first.
It's working?
Suction.
Not really.
It's not sucking or sucking?
No, it is. It is. No.
No.
No, it's not. It's not. Oh. It's not. I can hear any sound.
It's not sucking?
No?
Well, this seems like the machine is working, right? Hey Dave, can you call me? I need to figure out the suction.
Yes, hot. Second one.
Dave, can you call me, please?
Let's see what it is. This pouch?
Nothing is locked, right?
Pouch?
Nothing is locked. There's something
This is a pouch?
that you need to- Yeah.
Okay.
We're done.
This is the worst.
Let me connect it to the, do you have another diameters in the back? Maybe this needs to be connected somewhere. Oh, okay, I found out.
That's right, yeah.
This is what needs to be done. Now it should work. Try it again. This is why we are doctors. Now it should work. Is it sucking?
No, can I hear sound? There's no sound.
Does it sound?
There's no sound. Try that.
It's up to 102.95. I think the right holds.
Yeah, I think this is very low. Or maybe try switching the pressure. Yeah, there's some different suction somewhere. Now it's working like me. Not like it. Try this one. Try this one. Not sucking? Please call us so that we will figure out how the suction is.
Can you try and redo? See if that works?
First is a connection is correct or not? Is this machine connected somewhere?
Yeah. No, it's connected. It should be working. You know, there's suction here. And here's the suction here.
How about the other one?
This one also is sucking.
There's no sound. You see? I don't hear any sound. That does not mean.
Some setting is off. That's why it's not sucking. Is it sucking now? Is it sucking now?
Now it's going now. Okay now. 나 이거 뭐 발란다. 내가 뭐 하고 있는지 모르겠네.
Hey, I have a question. You know, we have this catalog. We have a Neptune. We can't get it to work.
고정이 안 돼가지고.
그래서 seems like it's connected and all that, but it's not sucking. Is it sucking now?
Yeah. Keep doing. Yeah.
Keep doing it.
Keep doing it.
What's in the working at online?
Yeah, working. Keep doing.
Hit the plus button. We did that, and then what we do? So plus button. Yeah. Okay. And then what do we do? How much do we turn it up? 250. Okay. So
250.
yeah. So that's what maybe it's not.
We were boarding back.
Yeah. So let's see. Yeah, the blue cartridge is in, so I checked
또 물이 또 들어갔나?
320. Let's see if it sucks now. No.
안 보이면 안 되는데. 드릴.
So it's up to 300 now. It is not showing that it's sucking. Which one should I connect it to? There's one which is there's one on the top. The top gets the one with the thicker tube or the small one. The middle. Yeah. Yeah.
One's on the floor over here. From the second side, I don't know if I'm connecting both.
First one is not.
Yeah. So it's closed. Then what do I do?
That was easy.
That's laminar now?
Yeah, laminar.
And the bottom is ISP?
Yeah, IAP, and the inside is, you can see the ligand flavor.
Okay, you're going to be here in 10 minutes?
It's
10 minutes?
foggy.
Is it sucking?
Not really. No.
I can still empty with this one.
You're losing soon. Okay. You have to. It doesn't work.
Okay. Okay, thank you.
Now working this time.
You want section?
Now it's working.
Not urgent?
You're trying to take the interior border of a tree off, right?
It's the lamina. So we have to reach to the uppermost ligament flavum. Okay.
How do you know you're at the border?
Yes, inside you can see ligament flavum. Punch.
Yeah, do we have any other custom canister that we can use?
되게 안 보이네.
This is not working.
So finding out bladder?
On the wall? Okay, wait.
Well, was that working? Was that working?
That's working?
Or a machine not working?
Okay.
Let me know that.
Okay.
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 아, 이게 돌아가. 펀치가 돌아갔어.
So you're just connecting it directly to the hose?
어,
Yes, sir.
물 압력 좀 decrease.
Push it down, please. Push.
물도 안 들어오는데?
Too low now.
Too low.
I'm gonna go up to 30, right? 30 or?
More than zero.
It was 30 before.
It's not working. Water.
No, you can't clamp. Okay.
Yeah.
Keep it to 20, please. 20.
Okay. The fork punch. It's lamina. Okay. Can you see the ligament flavor inside the?
Taking that down there?
Yeah, it's a ligament flavor, right? It's not clear because it's
So this should be dura coming out.
lamina.
This is a dura.
Yeah,
This is
yeah.
the ligament
So we have
problem.
reached
Can we clear that up a little bit?
uppermost ligament flavor. It's not clear.
Can you clean up the camera maybe?
Camera program. Hold again.
Here's the tip.
Again.
No, the tip of the camera.
The BT. Yeah, that's better.
Much better, better.
Punch. 4 millimeter. Water.
You just got to change the angle.
Yeah, that's it.
See the angle?
Water? Yeah.
Oh,
It should be
Snap the water.
Yeah, you want it straight.
okay.
It's okay or not?
It's on there.
Hold on. Just do it. I mean, let me know.
Got more land on
This one is working. That's good. Working now.
It's working?
Yeah, yellow ligament.
Perfect.
How did you fix it?
I have no
There's
idea.
one is working, one down. Now.
Stand it on it, just pick this foot up.
So this is working, right?
working, yeah.
Perfect. So let's not mess with it.
lamina.
So we remove the lamina now. Open up the ligament flavum.
Okay, boss. This should be working too.
Yeah, it seems like it. I can see that.
It's working. Perfect.
Okay.
You got this guy got spinal stenosis.
Yeah, good case to show.
Yeah.
So where is the lamina is, you know, so you did the spinous process here.
Just process the lamina, right?
Yeah.
During this part.
So you can still on the
So
top
two
part?
local is a spinous process. Cranial, lamina.
Okay, we have reached to the uppermost
This is the
flavum. It's the final destination. Okay, you can see dura.
Yeah, that's the end of the
So
ligament flavum.
you've gone all the way up to the border of the ligamental flavum.
Yeah,
And that's where it ends, right?
the first
That's when you do microscope laminectomy, we do it this way. Same way.
You go up to, you go up.
Yeah, so you have to remove 2/3 of lamina from bottom to up.
Yeah. It's all
Expose the
performance
ligament
flame, right?
Then you see the edge and then you take it off.
Yeah.
And then, so using the endoscope, the turning, right?
Rotating.
It's a ligament flame, right?
Yeah.
And then bite and the turn, we can see on the side, right?
Yeah.
Between the dura and the ligament flame. Right?
Brains okay.
It's okay?
Continuous irrigation dissecting between dura and the ligament flap.
At the same time?
No, the irrigation pressure is dissecting away from dura, away from the ligament flap.
Oh,
so
yeah,
you can grab safer.
Yeah, nice.
You should be careful.
I didn't follow that.
So continuous irrigation create the pressure, right?
Okay.
Constant pressure. It dissecting between dura and the ligament flap.
Yeah. It's
Make a clear space to grab the
If you
additional.
want to get a little hands-on experience, Dr. Kim will let you feel
Good
it.
job.
So you can put on gloves and
Hydro
hopefully when
dissection,
he's ready for it, he will let you feel it.
I can feel it by looking at it.
Yeah.
Not clear. Okay.
What do you need?
Yeah.
Again?
Yeah. Do we have the alcohol?
Yeah.
Alcohol.
Alcohol?
Yeah.
You spit on it, it won't fog up.
That works all the time.
That's what you do when you're scuba diving, right? You ever do that? When you scuba dive, you spit on the inside of your mask, clean it up, it don't fog up.
Yeah.
Because that won't go over too big. Real operator.
I'm putting a whole box of the alcohol pads here.
Yeah. Well, you got,
Listen up, listen up. 알코올 되나?
알코올은 좀
이 정도?
흡수가 증상. 이게 제일 안 좋은 내식입니다.
이 물이 세고 많이 안 되지.
Okay, punch again.
yeah.
Okay. Water please. So I can.
So are you removing a section of the ligamentum flexus?
Yeah.
The yellow ligament.
Inside you can see dura.
But I thought you get, when you do that, you get scarring of the rest of the ligamentum above and below where
There's really none above and
Yeah,
below. If you take
whenever
Taking
you
out the whole ligament. So.
the whole ligament.
so that's a,
in
stenosis. The ligament flapping causing stenosis, right?
Yeah.
So you have to remove the ligament flap to release pressure on it and release enlarge the size. You cannot.
So what happens to the proximal section that's still there, like cranial?
So the ligament problem is there is a no ligament problem top 1/3 of the lamina exposed. There's bare.
Okay.
The ligament problem is not collected 100% continuously. Each segment ligament problem. Oh, there's no ligament problem. Another ligament problem. Something like that.
So you're just removing the medial section?
There's an area, yeah, you own it.
Got it, okay.
Level.
In other words, the ligament of palm just closes the lamina window.
Yeah.
In other words, as soon as you get past the borders, it ends. So you just take off a little bit of the lamina and get to the edge like you got to the edge, and you dissect it down.
Got it, okay.
And you don't have to take it all. I mean, you take as much as you can. It's always going to help.
Is that the not
Dura.
looking at it?
Yeah, underneath is dura. Yeah, there's like a pinkish is dura.
The dura, right?
Yeah, that's dura.
That's it.
Yes.
Like, even when he took that down, tremendous.
To expose the dura, and then the ipsilateral to contralateral side with decompression. This is ipsilateral area.
It's separated after the water pressure, like the ligament?
Yeah, because they're not attached.
Yeah.
Unless he starts.
So just the pressure on the outside.
So it's a Jura, right? Yeah.
No, I think she's okay. Kind of.
Really? Now you can see this real nicely.
This should expose the lateral margin first.
Yeah. Is this suction working?
There's a lot of water coming down on this side.
Now working then?
I don't think it's working. Is it?
It's working, but it's detached.
And you're chipping away now at the lamina again?
No, it's a little flavor.
Oh, still ligament. Oh,
Yeah,
okay.
it's to expose the lateral margin. It's I think the okay. So you can see lateral margin, right? Jura.
Yeah, I see that. Can you clean the camera, please?
Look up to some latex sponge, anything. Sure.
That's the flower, right?
It's the lateral margin. Yeah, drill again, drill this. More.
Well, the medial is 6 o'clock, right?
Yeah, facet joint. More. So, won't work as much as we need. Wow, it's a serious scoliosis.
So 12 o'clock is medial.
12 o'clock is
6 o'clock is the lateral.
Yeah.
9 o'clock is cranial.
Okay.
You use all of them.
Again. So for me.
Clean up.
This.
What's the diameter of that scope?
The 8, scope 8 millimeter.
That's an 8? That looks good.
Yeah, 8. And
That's a 10.
yeah, no, 8.
Is it an 8?
Yeah, 8.
I mean, it looks shorter, it looks shorter, it looks wider. That's what my growth does.
Water. Okay. Okay, dissector. You have a dissector?
Show me a dissector. Did you turn? Good dissector? Yeah, dissector. Dissector.
Yeah.
This one?
Show you anatomy now?
또 저러네. 또 아니, no. dissector.
You can't see anything there.
This is. Goodness. You have to do again?
Yeah, do it again.
What am I doing that? What temperature is that water?
That
That water
I think
warm?
the fluid is leaking down already.
Oh, it's kind of. 집에 갈랍니다. 끝나고.
집에 가고 싶어. 이렇게 water?
Yeah. So yellow is the epidural fat, right?
It's a disc space, right?
The disc space.
Annulus. Right? It's a lateral margin of dura. It's annulus.
Yeah.
the one down there. How do you say that?
Ipsilateral decompression, right? And I'll try to contralateral side. So drill again. It's a spinous process, base of a spinous process, right?
So you're gonna decompress the other side?
Oh, yeah, contralateral side.
The camera.
You can't work under these conditions.
그래서 어떻게 해? 못하겠다.
I think that we have to abort the case.
안 해. 이거 뭐 다른 거 뭐.
I don't think vision was the blame.
Okay.
You know what? Maybe slow down the fluid.
Punch two.
And it'll do that less.
Punch into 보세요.
Two.
It's the contralateral side.
So undercutting spinous process, right? And then drilling contralateral inner cortical.
12 now lateral and
The 12 is a medial spinous process.
Medial side.
Yeah.
You know what you do? You look at the scope.
No.
Look at the scope, and you can tell which direction it is.
Okay, guys, it's done.
하지 말자. It's impossible.
What's causing it though? You just fog it up.
Sometimes in both Cadaveric.
north of the scope
Yes.
is medial.
Let me get it.
In other words, you look at the scope. You see the scopes like that?
So this is at 12 o'clock.
12 o'clock, 6 o'clock, 9 o'clock.
So if he's facing like this, that
There's a
means
12 o'clock is a
12
medial,
o'clock
the
is
spinous process. Facet joint. Spinous process.
Where's, okay, this is the
Patient left side. This is a patient left side. The left back.
okay.
This is lateral.
This is left side, this is right side, right? So 12 o'clock
12 o'clock.
is lateral.
We need to do surgery. 12 o'clock is a medial.
No, I mean, if this is midline, right? Then 12 o'clock is lateral.
No, medial. This is 12 o'clock.
Is this half a patient? Or is
This is left side.
But the endoscope we can turn.
I know, but if you're on this side of the spinous process, then this side is lateral.
Oh yeah, if you go to for the lateral,
That-
it was not there.
So I thought he went to the contralateral
Not
side.
yet. Yeah, you're right. Yeah,
Oh,
not
okay.
yet.
All right, that's why I was.
하지만
I think we're done. It's done. Right?
아니 뭐 와 있지도 않고.
On the inside though, right? Okay, comfort? Okay, let's take a look. So, difficult patient, right?
No, the problem is the
Turn the water pressure up. It's so frozen and tight, you don't get it like. Alright, what is gonna be the plan? Where's the X-ray?
Thank you, doctor.
Which one, you want the transforaminal?
Yeah, if you start on mic them
Yeah, right here. What's that? Have you go right here and save? Don't let anybody know, all right? Oh, no, I'm going. Doctor comes to this.
Can we get the X-ray?
Yeah.
And this is a lot more like familiar. This would be just like if you're doing a nerve block.
Right.
Same thing, except I go way low. Right? Instead of like, you do superior.
Yeah.
So
You do
I know
like
what the
under.
yeah, I go to the inferior patagonia.
Right.
I know you guys are worried about blood
Reverse
vessels.
safe.
Yeah. Yeah.
I do that only if
Can we get the X-ray tech?
What Dr. Lim was doing, just to make sure I understand, he was doing basically endoscopic laminectomy.
Laminectomy, full interlaminar laminectomy, and we're going what? I'm going transforaminal with it.
Just going second?
Yeah, different approach. And most that's just mostly for spinal stenosis. This approach would be for 90% of the discectomies. If you have like a big L5, S1, central herniation, then you still have to go this approach. But I would say for 90+% of the discs, you can go transforaminal. Where's the X-ray tech? Can we get?
Me. Even spinal stenosis, would you in your own practice do it?
I do 90% this.
Even, so what you're doing is even for spinal stenosis?
Huh?
You would do your approach even for spinal stenosis?
No, spinal stenosis you have to do that. But the thing is, a lot of times you have spinal stenosis, but it's mostly radicular symptoms. They don't have true claudication.
I just gotta pull this straight down.
Yeah, let's do AP.
Hold on. You could put that in right now, actually. AP coming up, guys.
Nope, we gotta pull towards you. Oh, wait. They put the CR.
What?
You know what? It's easier to move the patient to you. Go ahead.
X-ray?
Yep.
Right down now.
Oh, no, pull towards me.
I basically have you ready, just hold on 1 second.
Go ahead.
Okay.
Yep. Beautiful. Go up.
Up.
Oh, you can't.
I will try. No, I can't. Oh, that's why I can't. Got it?
No.
Nope.
This, if you were my X-ray tech, I usually make a joke and I say 07052 because that's a zip code of our. I'm like, let's get back to the right zip code.
All right, so
Down or high?
Down.
Down.
and then you have, what do we have left up here?
Come down even more. Yeah, and push in towards me.
Sorry, this machine.
You know what?
Sorry. All right.
Yeah, that's good. That's good right there. You know what? We'll do the one level above. We'll do 3-4 to make your life easy. Go ahead. Oblique a little bit more towards me.
Oblique.
Go ahead.
X-ray.
Keep going a little bit more. It's the same thing. 5 more. Yeah, 5 or 10 more. 5. Yeah.
Yeah.
All right.
I'll bring the machine.
I'm just gonna do 3-4 just to make it shot.
I just gotta move this straight so we can see it on camera.
What am I
Shot.
doing wrong?
No, you're good. Shot.
You're doing this is what you call doing.
Yeah. Yeah, exactly. Shot.
So you're
So we're trying. So I'm at the. Yeah, that's the SAP of the 3-4 joint. Yep. I'm gonna. Go ahead. Oops, too. Can you go up? Give me more room.
Sure.
Nope. Up.
Other way, I know.
Go ahead. Shot.
There we go.
Shot. Shot. All right, good.
This is like disco.
Yeah, exactly like that. Shot. All right, AP.
Nice.
No, more. Yeah, there we go. Better. A little bit more. Just, yeah, go ahead. Yeah, I'm hitting. Shot. All right, go to the lateral.
Bravo.
So now, just like a disc, I want to be sure that I'm past.
So that's the same way, right?
Midline.
Triangular camber approach.
Yep, yeah.
SAP.
I would have wanted to start off a little higher, but between this patient and our constraints.
It's an RF needle? Is this what
That's what they're having, but you don't have to use an RF needle. And then adjust the wag.
So this is basically a finder. You use a needle to find.
All right, we're good. I mean, I was at the medial border of the pedicle. Or there. It's not ideal. Like if I was to put a cage in, it's not an ideal angle because the cage is going to hit the top of the. If this was like real life, I would have taken it and like angled it more from like the. I want to be for a discectomy. It doesn't matter. Okay. This is perfect for a discectomy. But if I was actually putting in a cage, it's like the angle is off because if you extrapolate like a cage going like that, it's going to ram into the vertebral body.
Yeah. How does it look,
But for a disc, we could do that.
Maybe save that spot. X-ray?
I got
you. I got your next step. Are you push the machine in? I might dump this. Yeah, this thing will fall. Right.
Oh boy.
Oh.
Picture.
No.
No. Yeah, there we go. Yeah, that's fine. All right, Brad, we got a wire?
Yes, I do. Yep. Let me see, I didn't see where the blade was. Let me just try to find one. Did they have one over before?
Yeah, they did.
All right, maybe down here. I was looking for one. Oh, here we go.
All right, give me your dilator.
You got it?
So you can go up and down and medial lateral, doesn't matter.
Sequential style, so it's just a.
Are you going for the disc or?
I'm gonna go for the disc.
Just how far do you go with the wire?
Oh, you're inside the disc. You're middle of the disc.
Okay.
You keep that trajectory.
Back.
I'm just gonna go short like this.
Yeah, it's fine. That's fine.
You make vertical incision.
I do. You can make it's more cosmetic the transverse, but shot.
Sure.
Pull towards you. Just give me the cannula. I think we're good. Yeah. It's okay. We're just correcting for that. We're just correct.
Watch your hands. You want us to take the middle one out, or it doesn't?
No. Oh yeah. It doesn't matter.
Nah. No, it's immediate.
Shot.
You can fix it.
Come down towards the foot. Yep, there you go. Yep, perfect. All right, good. I'm gonna take this out. You can see I'm right on the facet. I would check a lateral, but we don't need to right now. It's fine.
I'm not a good X-ray guy. I'm gonna.
No, that's why we're.
It's because of this thing. No, it's good to move it.
Doc, I was gonna grab you.
Grasper?
Yep, I'm gonna grab that right now. So sorry.
Oh, that's why there was so much water. There's no stopper here.
That's what they were saying. He said normally you might have some tape on the
on the back you want? I got. Take that one for right now. Do you want the gray adapter?
Yep. Shot, please. Oh, you moved again.
I did not.
I probably.
You gotta lock it.
What's that?
Okay. Get that halo off a little bit there too, but.
Okay, I'm locked. Wanna take a
Okay,
shot?
shot. Yep.
Nah.
Too low.
Hold on, boss. Let's get the X-ray right. No.
At 3-4 should be done.
I'll grab some tissue in a second.
What do you need, boss?
All right, you know what, it's okay. I managed to show it to you visually. Give me the element, Brett.
You got it? You want the adapter on it?
Yeah, just put it on. No, I'm going to show it for set and choose. So that's pedicle. I mean, I already know, but it would be nice to always. So the first thing that stops you is, remember I put the needle? I put the needle right against the facet joint.
Right.
The needle will skive past it, but then when we put the other dilator in, it won't skive past the facet joint.
Right.
So you end up getting stuck just lateral to the SAP. You know, the needle went, like I bend it a little bit and then make it go into the disc, but the tough like dilator is not going to do that. So then I know this is SAP.
I'd love to see the placement, huh? I don't want to take your hand again.
And this area is going to be the. Can we try to get it shot?
Yeah.
No. Pull towards you.
Towards me?
Should get rid of that camera thing.
No, it's towards you. That dial.
No, it's not towards me.
The leg is caught on that side.
What happened to the X-ray tech? We had him, right?
Yeah. I can get a
Hold on, can you lock that leg, please?
Wait, is this hooked up?
Hold on.
Yes, it should be. It's not. They're not phone.
You know, just make it 45 because this is like
Yep, you got it.
frozen. You see, like you can see that this is a little bit smoother. This is the pedicle.
How do you know?
This is the SAP. We usually land right against the SAP.
Right.
So you can usually follow that down, and then you see the smooth curve bone. So I know that's pedicle. Before, shot please. I guess sorry.
Wait,
that's just a force of habit.
Let's try to get it right, boss. We're not that down. I guess we are. We could come in.
Pull towards you. It's easy. Yep, there you go. That's it.
No.
Oh, and down towards the foot. Down, yeah, this way. Yep, that's it. Shot.
There.
Yeah, you see? That's pedicle.
Right. So you.
And I could tell that because you see, this is facet SAP.
Right.
So you follow the SAP down, and then you get this round curvature. That's the pedicle. So, yeah, the camera is also.
Yeah.
You see now? Okay, now you can see it. You see, it's like a smooth. It's like a smooth. Okay, now. Yep, right there. That's the SAP going into the pedicle. So now I can go a little bit deeper and grasp her, and we're going to be right on the disc.
So that's the soft tissue, right?
Yep, soft tissue from the.
That's the pedicle at 3 o'clock?
At 3 o'clock is pedicle.
Yeah.
And if you take a shot right now, it's going to be right on top of the disc.
Hands clear?
Yep.
Just
Yeah.
going back to SAP.
Yeah, that's it. This is the pedicle.
Right.
We're attaching onto the vertebral body, and there's disc. It's very blurry.
I can fix that.
So this is your disc, right? Right there.
Yeah.
So your disc is right there?
Yep.
Just that's some irrigation between the.
There you go. There's disc. Sorry, this visualization is.
I could fix it for you when you have a second.
Is that the typical angle you want to go at, like from?
I went from bottom up. I mean, I should be more in line, but we just couldn't get.
Got it.
I didn't want to replace the needle just because it wasn't that easy to get shots.
Thank you.
Without throwing anyone from California under the bus.
Yo, East Coast people.
Yep, there you go. It's disc. You see how I'm going through?
Yes, now I see it.
And that's what your landmarks are always SAP, and then you can follow that down, so you're not hitting nerve, pedicle, and then I can go right into the disc.
Yes, right.
That's why like that triangle is.
Triangle account and safe.
Give me 1 second, Doc. I just want to. When you're good, I want to fix it.
Oh, somebody's wrong.
No, that's not because it's live. Actually, I'm just.
Grasper?
Can
Can I just split this real quick? Let me see if this will work. I just want to try to see if I can give you a little better visualization. That help a little bit?
Nope.
Or no, that's not. It's not even connected.
right.
All right, grasper.
Yeah, I mean this is
Here, this one's fine.
this is gonna be fine for like a disc.
That one, or I got the regular?
That's okay.
Yeah.
And if there's a herniation there, you would typically see it at this point?
Yeah.
It'll be popping out.
Yeah.
It'll be popping out, or sometimes you have to do more facet, but it's gonna be interesting. Give me the kerosene.
You got it.
Right.
Kerosene coming up. I already put some, I know put some metal blue.
What's that?
I'm gonna put in some metal blue on the contrast.
Yeah.
So you can see the blue thing come out.
Right, the kerosene, do we have the biggest kerosene that they make at Hudson and wherever?
I'll make sure I have it for you.
Yeah, he was telling.
The 4.0 is the biggest for this.
Yep,
scope.
yep,
Yeah.
exactly. Yeah, can we make sure we have the 4.0?
Yep, no problem.
And there's actually the nerve root. It's very, very hard. It's very blurry. And that's what happens usually in like frozen tissue, the grasper.
Yep, grasper, you got it. Here, use that one. That one's clean. I'm gonna flip this kerosene for you too.
Because we can't see the anatomy too well, I can actually just transition to the fusion.
Yeah, okay.
Let's do it. Give me a wire.
Wire, you got it. Come back up.
Shut.
There you go.
Alright, I'm in line.
Do you have the
I know this is, we're trying to do the entry. But let's just say we did a disc and this needed the fusion, right? I had the perfect visualization of the disc. We just dropped a wire and I retracted the nerve root. It's being held against this. Shot. Yep. Number one. Where's the globus? The number one, the little dilator.
Do you have like the dilators and stuff?
Yep. Cool. Let's do it. Mallet.
I got a mallet.
Yeah, give me the number one first.
Yeah, sorry. What's the signal?
How did you retract the nerve root?
With this, with the cannula.
Oh, got it, okay.
And
because
you just
went past the pedal.
Yep, exactly. And you could actually, I actually did it visually.
The nerve is outside of the channel.
I know that it's outside this channel.
Yeah.
Shot.
And that's the actual port then, right?
Mallet with the impactor. You have the first impactor.
We do not have an impactor.
All right, fine.
This is a trial. You can impact it.
Shot. Shot. Lateral. See, now I have the channel straight to the disc. It's now the nerve is against this, but all of these don't have much tolerance, so they're designed in a way that nothing can get stuck between these two.
That's the impactor? That's the adjustable style. Gotcha, okay.
Shot. Up. Oh, no, down. Or the bed up a little bit. Yep, perfect.
So you use that as an impactor possibly?
Here, here. Over this. One more and then
Oh, okay. One more?
that's also 8 millimeters. You can slide the other one. I'll put that on.
No, but we need to be able to. Shot. All right. We wouldn't. Do you have something to take this out? Yeah, there you go.
Muscles?
No, no. There's specific impactors for like each one. Shot.
Yeah.
Shot.
Thank you.
I would not do that in real life because you could get something stuck in between. But there's specific impactors so that, and there's no tolerance like between these two. And there's different impactors, so you wouldn't take one out. Shot. Shot. You have
Yes, we don't have a removal.
the wrench.
I was gonna say I got a coker, maybe I can grab you. This should be that.
Shot.
Yeah. I mean,
Shot. Too much. But that would be, now you have a can.
Oh no.
It's okay, give me the number one.
Here's the.
you got them all up there.
Yeah, that's why we need the wrench.
Yeah, let me double check, but this is just
Shot.
so I don't think we have it.
Believe it or not. I don't know why it's always hard the first time, but usually very super easy to find it the second time. Shot. Shot. You know, I mean, you would not do this because in real life, you would have to start all over again by visualizing the nerve root, retracting that away, and then doing that all the steps again. There's no way I would I would put that right back in, like, because that's just way too dangerous. But for you know, just demonstrative purposes, it's perfectly.
Can you put this over the back and hit the side?
Yeah, it's okay.
Yeah.
Shut.
On my machine.
Shut. One more time. Perfect. This is like the ideal placement. Both the entire opening is after the spinal canal. So any instrument that I pass through is only going to open between the two end plates. I'm not going to grab a nerve, I'm not going to grab anything, because both my medial opening and my lateral opening are behind. Grasper?
Yep.
Expandable shaver?
Expandable shaver right here.
So, and this is the key, usually, you know, between, you don't have to open, because normally when you have to open, because these instrumentation, before they had expandable instrumentation, and this seems simple enough, but this is actually a patented thing from Willis to be able to expand with a wrench mechanism, to be able to expand evenly on both sides without having, I thought it would be easy enough to design, but I guess it's apparently not. Go ahead. Shut. See, you can prep the disc space. Shut. Shut. Grasper. The big one, yep.
This is what they want. It's like a double action.
Yeah, that's all good. Shut. Yeah, I mean, it's usually that kind of just places it from the end plate, and then it's easy to grab after that. Or they have actually a bigger suction that's good enough to shut. You know, usually before when I was doing an MIST lift, somebody else is retracting my exiting nerve root away while I'm doing this, and you just hope that they don't let go of their hand. Usually if it's like resident, sometimes it's like, I swear half the time they would get 2 weeks of pain because somebody retracted too much, or somebody didn't retract it when you're going through with a distractor. Yeah. And this is the one, this is a straight channel, right? But you want to do a discectomy around. So if you look at this goes straight channel. It's getting the disc from top down, and then you can flip it, and now you're creating a channel this way. That's mostly so that you can get bone graft in there. Shot. And it just opened. And it's getting the disc from outside the same plane that we're going in. So it goes in closed. Shot. Yeah. Going with the camera?
Yep, camera's ready. Just get
I mean, you could go in there with the camera, burr, whatever. You know, there's a lot of different instruments. There's some, you know, superficial fraying, but if you see past that, you could see the end plates. And curette.
Is it like a?
Yeah, the globe, the curette.
The only curette we had is that articulating one.
Oh, you don't have the regular curette?
No, no straight curettes.
Okay.
I apologize.
No worries. You just do expandable shaver.
Expandable shaver. This one.
Shot?
It's like our articulating curette.
All right, we could put the cage.
Cage?
Yep.
Cage right here.
So there's a cage on the inserter. You can impact the back of that, and I've got the expandable driver.
So then there's an attachment. You could put a funnel, and I would pack this with at least like 10 cc's of bone graft. Pack it anteriorly, and really the cage.
I think you're just gonna hit on the back of that today.
Yeah.
Yeah, we have the tube in the funnel. Let's show the back.
Now,
The bone graft is packing up against the annulus.
Against the annulus. So there's a little attachment. I could pack this with 10, 15 cc's, whatever you want.
How you measure which one?
Oh, there is a
A trial.
There is a trial. Usually at 3-4, you can easily get a 34-36 because you're going at such an oblique shot. Shot.
I wasn't here. You put the SAP dead center.
Yeah. Shot. Shot. All right, check the AP. Let's see where the cage is. You have a little expander.
Do you want the funnel to show or?
No, yeah, I could.
I got the funnel and the
No, it's good. That's good.
Have a pseudo.
Go up and pull towards you. No, no.
Web is not locked.
Yeah, yeah. There you go. Keep going. Yep. Shut. And do you see what I mean about fixing the needle? No matter how it looked before, remember I said with that needle we're going to be jamming this cage towards the other end plate. And you know, you can always force your hand, whatever, but that cage goes in the trajectory of your original needle. And now it's not sitting in you know, if you look at my x-rays, they're sitting like right against the end plates. This cage is not, you know, sitting directly against the end plates, but I knew that the moment that we got that needle shot in the beginning.
Perpendicular to the end plate.
Yeah, you want it to, you can't, yeah, exactly. Actually, you can see from, we put a scope there, we put 100, like a lot of different other instruments that were in line, but when it finally comes down to it, it's gonna go the original trajectory that you did, that you placed this. Shot. Yep, shot. Go to back to the lateral.
That looks much better in lateral.
Yeah. I mean, like I knew that when we put that needle in, it's going to be.
Picture of lateral.
Yeah, normally if I was doing a disc, I would have left that needle okay. If I was doing a fusion, I would have changed that needle. That's, yeah, and then you would expand.
And that's maximum expansion?
Yeah. No. It didn't expand as much because it hit the other end plate. It hit the tolerance. Normally at a 3-4, you would have gotten because it's hitting the superior end plate. There's too much pressure up here, so it's torquing out.
On the image, this looks okay because it's not, the end plates aren't lined up.
Yeah.
8 to 11. The next one's like 10 to 13. So depending on your height you think you're going to go, and then it does torque out when it gets that resistance.
You're going to take it off the other, yeah.
So it really just depends on where the plant side.
All right. Oh, the cage came out.
No.
Well, that's good. Somebody doesn't have to dig it out because they can't take. Normally, once the course is done, somebody's job is to go in and get that out because you can't bury the body with new implants.
I gotta get the radio lucid one, but I don't know.
I like that.
But you know, and then you would do the same normal screws and stuff. But it's. I mean, I could put this back just for the shot, but. There you go. Shot. Yep, you're right on time. You didn't miss a thing. I'm just kidding.
Thank goodness.
Shot. Shot.
Over here.
Yeah, I mean, I'll leave it there if they want it, but it's not.
Now, Doc, do you mind with the recording? I just want to take a look at the head. Excuse me. I just want to see the head.
No, don't worry. I just want to leave this. Do you want me to? I don't know. Don't. Shot.
Oh, I'm right here.
Now it's expanding properly. There you go. I just changed the trajectory. Yeah, you could distract this as much as you need to, even on like a collapsed disc. Okay. Yeah, I'll leave it there so we could take it out.
Should rotate it or he?
No, we're good. We're good.
No, this, the head.
Go to the AP. Just get a nice AP. Save that shot. And we'll just take it out now, so it's why you don't have to dig for it later.
Yeah. While it's still attached.
I thought that they just leave all the implants in, and then somebody was telling me that later on they go in and start digging out all the
found that
implants.
out recently too. I didn't know that because we had a course about a week ago, 2 weeks ago.
Yeah, you can't leave
We didn't
anything.
do any implants, and they asked me, and I'm like, no, there's no implants.
So
We just did
why are you gonna take it
endoscopic.
out?
How you doing, Brandon?
Because
what's up, buddy? How you doing?
like if the family like depends on the cadaver. If the
he was trying
family
to
wanted
work
it
with it,
like
so it might have-
reburied,
I'm just
then they won't rebury it with like other, like foreign stuff.
So we have to
Yeah, depending on what like the
you gotta get a company that don't care.
yeah exactly.
There you go.
Yeah. It's good. Shut. Yeah, try to get the spinous process in the middle.
I got you.
Yeah, it's digging into the body, but we kind of knew that. All right, the lateral looks the best. If you want to take it up.
Swap it.
It's this one is not working. I couldn't disengage it.
Okay, well, you know, it is, I don't know what your guys' plans are moving forward. That is a demo, so technically it's not supposed to be implanted, I don't know.
Oh, okay.
I wasn't told what the procedures moving
All right, I'll take it out.
forward, sure. If it's all the same.
Yeah, I'll take it out. No problem.
So what are you doing? You're putting in a cage?
He just did, yeah. So he kind of did discectomy all endoscopic, and then did.
Oh, I did loosen it a little bit. That's right. It's all good.
You changed out the dilators.
Thank you.
Do
Do you need anything else?
No, no, we're good. Just focus stuff. I'm gonna get out of here.
And then when that goes in, then you just spin it. That's what we do.
No, thank you. First time I see it get out.
Oh man, smells good, doesn't it?
Yeah, so I was like,
Yeah, what we do other cadavers labs, they cauterize, they get through, so it's just literally burning.
I'm Justin, by the way.
Dead flesh. Austin. I'm the rep for Globus Medical.
Nice to meet you, man.
Yeah, nice to meet you too.
Yeah, I've never seen one of these before. It's interesting. But I mean, Michelangelo, so like,
Yeah, right. Some of these surgeries look like tortured otters when you get it.
Well, he was a sculptor, Michelangelo.
Yeah. Yeah.
He understood the body. Like a surgeon. That's how they were able to draw something.
Jack.
Okay, but Michelangelo was like, I have to dissect it. You don't have to draw it.
That's the dirtiest shrimp.
Ash.
Everyone saw that watch. I know.
Thanks, that was awesome.
That's going on my son's. Actually, I bought it like the week he was born, just for that.
What year is it?
Huh? What year is that? 2020.
Yeah, you look at it again. I'm just obsessed.
So it's actually makes it because my son was born in January 2020.
Congratulations.
And that's what makes it even harder to find 2020 because they need so little that year.
Is it ceramic? Is it not ceramic?
It is ceramic.
Hey, where is it ceramic? Show me.
It's just this blue and the red is ceramic.
Okay. Because this is stainless.
Oh,
This is 2004.
Yeah, that's why.
Yeah. So I want that. But I tried finding it. It's hard to find.
Yeah, cut out.
Okay, we'll catch up. Nice to meet you, Doc. Congratulations.
No, that was just going to be a discectomy foraminal.
No, when you put a cage in, you.
Oh, yeah, if you put cage up, put screws in.
For this particular case, you would put.
Oh, yeah, I'll put the cage in, yeah, we have to stabilize it.
Okay, that's all. Because you didn't do that.
No,
Okay, fair enough.
That's
I just
gonna
want
be
to make sure.
standard. No, that's gonna be standard, you put the screws.
Okay. All right, I'll see you soon.
No, thank you.
Thank you.
You all right? I have this,
Just so you don't forget, it's interesting, my number.
Yeah, and then like, you keep the spelling of your last name?
Salem, S-A-L-E-M. Jag.
You should.
What's your, that's what your last name?
Desai. Yes.
Desai. Are you from, like Bombay or?
My parents are from Gujarat.
Oh, you are?
because we are taught in the course there.
Are we done until the next procedure?
Yes.
Okay.
Yeah, they're trying to. So, and not just in pain, but for example,
I mean, anesthesia was a good example.
yeah, that's the whole thing. And then that's the original. That's where we made.
That was the original sin.
That was the original sin. You know, and I'm in anesthesia, and you're right. That's the original sin. And then at the first step, but now, one of my plastic surgeon colleagues was telling me that PAs and nurse practitioners are opening their own account and their own cash billing for all aesthetics.
Injections,
Yeah.
I mean, honestly, that didn't bother me that much.
That's because it doesn't affect you.
Well,
just like, for example.
No, but I'm saying, like, you know, like, how much damage are you going to do by injecting Botox?
No, I understand, but it's all relative. Yeah, it's all relative. Right? So
But it does fuck up their paradigm.
Right, that's the key.
Yeah,
So
and
once you
take over. No, it was just, we need help.
There was a paradigm shift. Once you open up even the door,
Actually, look before I came here. Not only
그 길이가 딱 적당해야 돼. 이제 이렇게 되잖아요. 이렇게 돼야 내가 안쪽을 안 보더라도 듀라까지만 딱 갈 수 있게끔 거리를 측정한 다음에 힘을 주면서 푹푹 밀어야 이게 빨리 가지거든. 근데 이걸 이렇게 해가지고 큰 덩어리 울프 가지고 이렇게 하는 거는 살살 갖다 대거든. 살살 갖다 대야 돼. 그럴 때면 안 돼요. 이럴까 푹푹 밀어야 돼.
Can you shoot a picture? Let's see where we are. Yes, sir. Yeah. I'm going to adjust. Yeah, he's going to get the camera.
Okay.
See if you can do it. Yeah.
잠깐 엑스레이 먼저 보고요. 엑스레이 보려고 한다. 내가 지금 이게 많이 삐뚤어서 힘들다. 그랬더니 엑스레이 한번 보겠대. 지금 목 상태 어떤지 보려고.
Yeah, that's good. That's good. Okay. Let's just shoot a picture.
다 간 것 같으세요.
Come up to the neck a little bit more. Want to see if you can get the frame. Just shoot straight in. Sure. No problem. Action. Okay, what's showing up? Okay, there it is. It's just rotated.
It's not easy.
It's very rotated, that's all. There you go.
So what do you think about the transit HDF?
What?
HDF.
ACDF, okay. So we're going to flip it. You can't do it from here, right?
It's
hard, right? Okay, so
because it's the patient have a kyphoid chain.
Okay, so it's going to be
so
different.
just the prone position HDF.
Okay, ACDF is better.
Yeah.
So we got to turn the cadaver then, right?
Yeah. Yeah.
We got to turn the cadaver. It's not going to be possible to do this. First of all, what I do
HDF Pro.
he's going to be still because
I do it this guy.
안 들어도 되죠?
네?
안 들어도 되죠?
뭐안 들어? 한번 보세요 근데 HDF 하는 거.
I guess the guys are going to come later on. You know, I took care of some of the stuff because I didn't want it. This one's around. I know there's still bits to clean up here, but who takes care of the
가시죠? 지금 당장 안 해. 지금 이 바꿔야 돼.
start?
The professors.
We had to change the position. The spine HDF. 저게 포스로 포람트 하려고 그러면 목이 고정이 돼야 돼 이게. 고정이 안 돼 있어. 그러니까 차라리 뒤로 이렇게. 이거는 좀 괜찮겠지.
Yeah.
why me?
Yes, for both.
I'm the kind of bystander today.
Yeah. No, he asked for both. No, he asked for both, so. And how could you say that about yourself? You have nice hair. Come on. You both have nice hair, in fact. That's the first thing I know is like, oh wow, nice haircuts. I know how I want to shake my hair the next time. So you actually drill the brass that goes down there too?
And then the bigger one to the sleeve.
And then take up.
Look at the picture. We called everyone. So they got the cadaver. Let's take a look at the X-ray. Just don't shoot. No, then take a look.
Yes, sir. Steve.
Okay.
So your other job, you bounce, you do security? Kind of person I wouldn't want to buy.
So Dr. Lim, do you usually stand, I mean, when I do my anterior cervical work, I always usually stand on the right side?
Yeah, right side.
You usually stand on the right side, right?
Yeah, right side. Oh. I have to fix that.
This is going to be the ACD.
Okay.
Yeah. Yeah. So you have your retractor, right? Are you going to use your little retractor?
No, without retractor.
Without? Okay.
Because no retractor here.
Okay.
Yeah, without, I try.
I have a moment, sir. We're not going to start right this second.
We are going to, I need you to be here. Okay. Sticker.
Okay.
Please sticker.
I'm not moving.
Sham check, please.
Check.
Yes, sir. Yes, sir.
X-ray.
Check. Okay.
Yeah.
Okay.
Good. Okay. Can I get everyone in? You want to just cover this up and then start?
Yeah.
Let me just tell them that we're going to get started. We're going to get started. We just need the just like cover the body up a little bit. And you know, it's going to be not. When is your flight?
At 6.
6. So you should watch it because it'll be done by like 20, 25 minutes. Oh, okay. You know, you can watch it and see.
Hey, the man is doing all we want to watch.
So do you want to fix the camera now?
Interior.
Yeah, you can now set it because it's going to now get ready to do. Oh, it's already there. All right.
Procedure, you go in there and you burn the nerve. Right in the center of the. It's already pre-bent. You hammer it slowly, and it's already pre-bent, and it goes.
So it goes around the corner. And there's like a sharp tip or something.
It's not a sharp tip.
It's a hard probe.
And then you pull out the stylet.
Yeah.
And then you put in the electrode. And you pull it back and you keep it right dead center behind the sinus problem.
Do you think the right position and then the energy would work better?
No, everything was probably great.
So just every instrument to go
근데 이거는 이제 물이 또 어떻게 빠지지? 더 복잡한데? 물 다 흘러가대, 바닥에? Okay. Okay.
Yep.
Okay.
Well, water.
If you don't want
Water temper.
Oh, water change. Yeah. So we need to actually have the pouches. Two pouch.
Right?
Yeah. One on each side. Yeah. Let me get my gloves.
How about the other one? This is working now. The other one?
I have ratios, and I also have business of doing things with the road line.
Drag here. Drag.
Is it not working so guys?
Well, it worked for a second, and then now it's not working. I don't know what's wrong.
I'll take a look.
Yes, no.
So, do you want me to cover this part with a little drape, or you're okay leaving this open like that? Do you want me to put a little drape?
You can use this one, right? We already opened up here, but
The drape, it's like a gown. It's okay. It's a gown.
This was a walk-in, but this one I'm not 100% sure. Or we may have to get manually like that. It's not like that. It's due next year. Yeah.
Okay, Siam check. Siam. Okay. Correct. Okay. Alright.
Ready to go? Sir, yeah. You're standing right to the camera.
Yeah, I have. I have my phone. Okay, I'll start. So with the finger, we can palpate the physical space, and then how to insert. Siam check. Okay. Siam check. Siam. Okay.
Look dead center?
Yeah. Siam. Okay, lateral view. Lateral. Yeah. First, we will insert the needle into the physical space. Siam check. Siam. Okay. Siam.
And this is the device that moves the
Siam.
vessels.
This is the camera. It's not easy because. Siam. Siam check. Siam. 아, 이렇게 힘드냐? Siam check. Okay. Oh, how can I remove this? Siam check. One. 이렇게 되면 안 되는데. 이렇게 되면 안 되는데.
KY만 쓰시.
아니, 저거로. 잠깐만. Okay. Siam check. I don't know. Siam check. Yeah, I'll try. Yeah. 그 스킬은 안 해도. 칼 좀 줘봐요.
An incision, right?
Yeah, I'll try. Small incision. 전체. 전체. 시험. 시험. This one? This one? Yeah.
Nice. So this is your system?
Yeah.
So who makes this? This is not small, right?
No, myself.
Yourself.
Then, studio.
So Dr. Lim, how big are these dilators? Go up to like 7 millimeters? It looks bigger than...
시험 check. 오케이. 아, 막 돌아가니 고정이 안 되니까. 씨. Need to fix, but it's unstable.
Can I hold the hand?
Yeah, yeah.
Hold the head?
Yeah. Hey. 잠깐만. 그만 원래 써도 워킹 셀로. 워킹 셀로. 네.
X-ray?
X-ray. Okay.
Green, right?
또 안 되네. No.
Can you take care of that like you did the last time so that we have like good vision?
Okay, that's still good. There's no water in there, right?
나 포기 again, 포기.
Can you check?
Do you have another,
The second camera is in there. Can you open the second camera?
yeah, I don't even know if it's right though. Let me get you another,
안 돼.
Let him get the other set. Yeah, very good.
No. But soon there's a problem. Water?
Water on? Can you turn on the water?
Okay.
Yeah. It's actually now
Some check?
X-ray. It's actually better. I don't know what.
Yeah, I'm not sure we got to do it.
I think it was the same thing, you know.
Some check? Okay. The forceps, please.
Forceps?
Yes. It's anterior to antevertebral fascia. Forceps, please. Forceps.
A couple different.
The fascia and some check. Some check. 시험.
So he's not yet in the disc.
Yeah, vertebral fascia.
Vertebral fascia.
시험 check. Nice. Nice. No, no.
Yeah.
Should be.
Okay. X-ray again? Came out.
Yeah. Because. Oh.
Shut the irrigation.
Water.
Can you stop the water?
It's on, I don't know. No, not there.
Obturator.
Yeah. Well,
Not that. Don't go there.
Yeah.
That.
Okay, siam check.
Picture.
Yeah. Siam check. 시험? 이게 막 돌아가니까 어떡하지 뭐. 시험? 시험? 네, 시험?
You want an AP check or?
I think it's at the center. Okay. Yeah, let's go.
X-ray again? Get down a little bit.
시험?
Can you ask them if the light stream is okay?
시험 again. Check, 시험 check. Wow. Bipolar? Yes.
There's too much water here. Can I get the suction tube? I'll just put it here. Suction tube? Yeah. This suction. Now it's working. How come it's working now? It's working good now.
The only one working.
Okay. Let me hold that.
When they're hooked up to that, the fence is really good. I cut the plastic, so.
Yeah, it was not cut.
It's not working.
I think that's what it is, so.
It's not working.
There's like a little,
Is the bipolar working, Brad?
Not working.
now what is?
Yeah.
Bipolar? Check the bipolar.
Not working.
Not working. Brad, you want to change the bipolar?
Yeah, I changed it.
Can you change the tip to it?
No.
Not working?
No.
Change the tip, please.
시험 check. 시험. Okay, so
That's the disc.
Yeah, it's a disc space.
Yeah. So you see the white finish? So white is usually what the disc looks like on the endoscopic view.
It's a disc space.
Yeah, it's nice.
Yeah.
View, endoscopic views is marvelous.
Until the disc space.
So you're rotating the camera to view what? You want the disc.
Can I do an X-ray?
So can I use the RF? RF?
Brad? The RF. It was not working, so you use the RF Oh, okay. What?
I mean, on the X-ray, I know it looks like this here, but where the X-ray is, it looks like it should be both.
Yeah, he's going to work on it. Brad, can we check before we think that is working? Brand new one?
Yep.
Okay.
So is that connected now? Yep. Can you, Dr. Please check, make sure it's working? So you're all detecting the fascia there, right? It's not, that's the disc space right there, right? The white?
The first
all the fascia is to be detected.
So before the operation, with the indium coming, right? Blue stain. Yeah.
You want me to hit it? What do you want me to do?
Yeah, hit it. Is it working?
It's not working, what?
Oh, Indigo got me, yeah. Indigo?
Yeah. Shall I check?
Sure. X-ray?
It's a disc.
Yeah, that's a disc, right?
Yeah, disc space.
Okay, nice.
Check. Okay. Sure.
X-ray? Nice.
Yeah.
Now.
Is it this? Yeah. Sure. Okay. Yeah.
I have an indigo karma in here if you want it. You can inject it if you want it. I have that available.
Okay. And then, okay, use your punch.
Or punch?
Two please. Yeah.
So you usually use number 2 or number 1 in the cervical? Two.
Yeah. It's a what?
Here, probably to use number 1. And here,
yeah.
should be okay. Use the code to do probably, yeah, right? You code to it, number 1.
Let me know when you're doing next next workshop, I'll go and visit you again.
The people, we need to check out some instruments and camera system.
So that's probably prevertebral fascia, right?
Yeah, fascia.
Yeah, that's fascia, but he's kind of targeting the disc.
RF가 좀 잘 돼야 되는데 파시아 Some check. Okay.
So when please show us the PLL when you get to it.
So first make a space. 여기인데. It's a disc space. Okay. So first we need to remove anterior osteophyte.
So we use the drill for that, or?
Yeah, drill.
Do you have the drill?
Drill. Yes. First we have to.
The one with the 2.5 millimeter tip, right? That's 3.5. That's a 3.5. He said he used 2.5 on the cervical.
The drill that's available would be the demo system.
It's only the 3.5.
They do have the 2.5 available.
So Brad, has anybody done the, like I used to do that with Wolf, anybody doing it?
RF, please.
Right now?
There is a cervical system. It's different than this. It's smaller and like that. So, yes, we do have some improvements in that.
Working. Okay, clear?
Drill?
First, anterior osteophyte.
Okay.
Let's remove. Some check.
Nice. Yeah, all the way through.
Pull up, please. Yeah. Please. Sound check. Okay. Yeah. Punch, please. Yeah. 이게 말 왔다 써도 돼. 왔다 써도
What are you looking for?
punch. 아까 어디 갔지? 어디 갔어?
Picture?
예. 이거 맞아. 예. RF, please.
So do you always drill the interface or, just, in this case because there's so much of osteophytes you have to drill?
What's the fight?
Yeah.
Oh, it's not working.
It's not working.
It's not working.
Hey Brad, apparently the RF is not working. Which one is the new one?
Not working. Oh, it's working. Yeah, it's working.
It's working. It's working now. It's working. You can see the bubble.
Oh, fuck.
All bone. I mean, you can see.
Okay, ready? Until osteophyte. Okay. Punch. Sound check. Wow. Oh, 팔 아파. Sound check.
Check.
Sound check. Bipolar. Yes, bipolar.
Is that the right one?
Oh, it's,
What is it? He's watching this. He's watching.
yeah, working.
I always work on the right side.
Okay, clear. Wow.
Can you push the machine?
Yeah, it's all right.
Am I saving any of these x-rays to you guys or no?
No.
Okay.
No.
Sorry for looking.
No. You're in the disc.
Physical space.
In the disc space. So he's trying to go all the way back to the TL.
Even the other one that I like.
Okay, all set? The other one.
You are almost to the PLL now.
Okay. Punch, please.
Punch.
Punch,
They're
please.
making you work hard. Well, he's just showing the anterior discectomy. Yeah. Well, we'll see. Let's see what he can always
지금 문제가 자세가 이렇게 됐잖아요.
You want an extension?
너무 이거 반대쪽 더 콘트라탈 웅코부터를 조인트인데.
So where's the contralateral side?
네, 이쪽 콘트라탈 사이드 웅코부터를 조인트. 어?
Those are like kind of bigger scopes. Yeah.
Okay, can I use bipolar? Water?
Water's running out. Brad, can you get another fluid? Yeah. I have to get out. No, we have more, but I have to just go into the room to get it.
Oh,
I'll have to go and see where it is.
Okay, three. 이게 지금 자세가 안 나오니까 이상하게 되면 이제 엔드플레도 살리고 다 해야 되는데 지금 이상하게 갔어. 예. 아하.
scope. It goes into the scope. Scope. The only thing is you check where you are. You pick up the scope, and then you do it to the bigger system. If you do it through scope level, then you can
Okay, sound check. 바깥쪽. 아, 정말. 하다보다 이상한 걸 골라가지고. 자, 보세요. Yeah, I know. 이게 디스크 스펙이거든. 원래 이렇게 들어가야 되는데.
Brad, we're filming this, so I guess. No, they're filming it, so your voice is coming.
It's live or?
You're quiet.
Oh.
와, 바로. 시험 check?
I have to go because I think it's in the like storage room, but I'll have to probably go and check it out. It's almost done.
Yeah.
So do you mind?
Creating. Yeah. Some check. It's after a space, I think, right?
What's that? You're inferior?
No, it's here now.
Posterior.
Yeah.
Usually take about 45 minutes to an hour.
Okay. And then, Harrison punch. 2. I think it's just after a space. Yeah. Osteophyte, osteophyte.
Right.
Yeah. PLL.
I want to see how far we are. Oh, nice. Yeah, all the way. Wow. Lucky. I know.
What's up, please? What's it? What's it? What's it? And it's a Jura, right?
Right.
It's a Jura, right?
Yep, right below. Right there.
Punch. much. Okay. And then I will insert the cage. Okay. This cage. Cage 여기 꺼내놨는데 이거.
Dr. Lin.
Yes.
Yep.
이걸 빼주시죠. 이거. 이렇게. 넣는 방법을 가르치러 가니까. And then we have the retract, but I have no retract to pay. Right? So I'll try. Okay. 거기 없네. 워킹. 얘를 빼먹었어. 이렇게 하는 게 아니고 이렇게 되는데 이거 끼우고. 오케이. 오케이.
X-ray? No, I'm doing it.
Sean?
X-ray?
Sean?
X-ray?
Sean?
X-ray?
Sean?
X-ray?
Sean? Okay. Mallet?
Mallet?
Sean?
X-ray?
이렇게 되는 건데. Sean? Sean? On? Okay. Sean? 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 On? 왜 이렇게 됐지? Sean? Sean? On? Okay. Sean? 제대로 안 들어갔어. 이렇게 들어간다는 거 말고 됐지. 여기 잘못 들어갔네. 다시 홀드. 아이고. Sean? Sean? 잘 들어갔어.
Lost the plot?
Sean? Sean? 모르겠다. 돌아간 거죠? Sean? Okay. Process. 요거 말고 포스가 앞에 있습니다. 포스. 아까 쓰던 그 있지 않으세요? 너무 긴데 이거는 PLD 보세요. PLD 보세요. 그렇지. 안 보고 들어가니까.
You're trying to get that out? Yeah.
Water. 어디 갔지? 흘렀네 밑에.
You lost
lost.
lost the desk. Down there. Right there.
Yeah. Sure?
Yeah. There you are. See where it goes to line? Yeah. Right in the middle.
아이씨, 모르겠다.
There you go. No. Yeah. Left the two, yeah.
I think this one. Okay, what's it? Okay.
Oh yeah, there.
Hold.
This side, working. Yep. So this is made by medicine, the case?
Yeah.
Dave, you want to do this?
Yeah, I'm gonna think about starting the appointment. But I better have a better elicitation. with a little bit better disc.
What's that, please?
X-ray?
What's that?
Sure, it was a lot better.
Oh. Yeah. Okay. Okay. So today we have the skin tract. That's why it's difficult to find the space. Will you open it? I got something. Yeah. Sam? Sam? Okay. Marlon? On? 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 아이씨, 또 들어갔네. On? 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 오케이, 됐다. 점차? 시험. 시험. 아, 빠졌어. 시험. I feel free to retract because do you have the retract? 시험. 아니, 처음에 그 디스크 제거할 때 공간이 잘못돼가서. 진짜? Could I move this right? Look up. What is it? X-ray? Okay. So without the checklist, it's difficult to do. Yeah, go through, yeah.
Yeah, it's okay. Okay. You want to hold him? Take it out.
No, I'm doing 90%, 10%.
Yeah,
You see it? Some procedures I do. We'll see. They sold
use my gloves. Do I have blade, please? Blade? Blade. Just the blade. That's why I make the incision bigger. Sure. X-ray? Right on top of it, right? X-ray? We got the cavity nice. The space is here, right? Yeah, that's the space. Hold on, let me see. X-ray? 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 It's not through AP, right? Yeah. Nice. You want to check AP?
Yeah, let's stop.
X-ray?
Let's stop.
So right there. Yeah.
Oh, yeah.
So it's a little bit higher.
Yeah, there it is. This one? Yeah. That's the bone. That's the bone. I'm lost. Okay, let's go, AP. So we're not, anyway, we're not live streaming it anymore because. Okay. Coming up. 이게 보이는 게 그거였네. 하이웨이드본. 하이웨이드 바깥쪽이었어.
됐어. Next leg. Just you line it, make sure. Relax. There we go. Next leg. Go south. Next leg. There's a light.
It's not true, AP.
That one, yeah, that one, yeah. That one. It's not deep. You lost that neck.
Hold on. Then just control the same. Siam. Yes, no. Siam. Yeah, it's the hole is okay. It's through AP, right?
Yeah.
Where you shoot the cage inserted here, right?
Yes.
But
it went the other side.
I have one more cage. It's over there.
I put him in.
Brad, what do you want to do with the instruments? You want, my person is coming in at 5.
Someone's coming in to clean?
It's